Thank you, Sarana. And now I request Mrs. Rajeshwari. Thank you, sir. Now I request Mrs. Rajeshwari, project coordinator of Chipmas Mentoring Clef project to deliver the vote of thanks.
Good morning, everyone. It's my privilege and honor to extend the vote of thanks on this special occasion. On behalf of Plastic Surgery and Chipmas Mentoring Clef project, I express a heartfelt gratitude to all who have made today a memorable success. First and foremost, I thank our Chief Guest Dr. Ravi Kumar Chitoria, Acting Medical Superintendent, Registrar, Academic, Head of IT Wing and Telemedicine, who have graced the occasion with his presence and sharing his immense inspiring words and inspiring words with us. Thank you, sir. To our distinguished guests, Mrs. Pushpalata Man, Nursing Superintendent, SSD, Mrs. Devika Shrikant, Deputy Nursing Superintendent. Thank you, sister, for your valuable time. To our residents, speakers, and delegates, thank you for your contribution in making this program a success. Finally, I thank our organizing team members who have coordinated and made this event a success. Thank you, one and all.
Now I request all of you to stand to mention. Thank you to one and all. Now you can take your tea and stand. Thank you.
Funny time. Can we just practice? Which is the topic is on. We have to see. Someone no, you stand here with the hand mic there. Hand mic is there. Stand here with the hand mic on. Hand mic is there. Rule We'll start the sessions. First session is by Ghana Gupta, our senior resident. She is going to explain on what is cleft lip and cleft palate and what is the process of that treatment and everything. Please welcome.
Good morning, everyone. I am Dr. Ghana Gupta, senior resident in the Department of Nursing. If I can speak about left clinical palate, I hope everybody knows for so I guess everybody knows a little bit about left clinical palate. Will extend.
Where is Kavita? Where is Kavita? Okay. Oh, I think so. Light changer.
Change. Yes. With this, it's not changing. इसके पास चल रहा है
Good morning, everybody. I'm Dr. Kanav Gupta, Senior Resident, Department of Plastic Surgery. So I'll give you a brief introduction about cleft lip and palate. I hope everybody knows what cleft lip and palate is. We just elaborate on it. Okay. So the scope of our presentation would be introduction, etiology and risk factors, prenatal diagnosis, counseling, classification, perinatal and neonatal management, associated anomalies, syndromic workup, multidisciplinary care and long-term planning, embryology and timeline for surgery, and the role of left team. So coming to introduction. What is cleft lip or palate? It is basically a congenital anomaly in which there is non-fusion of the embryonic structures of the face. Therefore, there is a gap or a split in the lip. If it is a lip, it is called the cleft lip, and if the split or non-fusion is there in the palate, it is known as cleft palate. So in these diagrams, we can see in these photos, we can see cleft lip. Here also, here this is bilateral, this is unilateral, and that is parallel. Because both sides there is a gap. This is unilateral on the right side, and this is on the right side unilateral. But this is skin is there near the nose, and here this is the parallel. Non-fusion is there, which is there in the parallel. So, coming to the epidemiology, why is there a need to know cleft lip and palate? Is it so important, or is it so like epidemiologically common? Yes, it is very common. Every hour, we can say there are around 70 to 80 children who are getting born with cleft lip or palate. And in every year, there will be around 27,000, 33,000 individuals who get born with cleft lip or palate. So the incidence comes around 1 to 1.5 per 1,000 kids are born with cleft lip and palate. Yes, this is much common. This is the most common craniofacial defect. So that is why there is a need to study. And prevalence will be obviously common if it is seen more if parents have it or siblings have it. But general population also can get fixed with cleft lip or palate. So there is importance in early diagnosis, and because cleft lip and palate is generally treatable. Because cleft lip and palate is treatable. So there is very much importance of early diagnosis, and if diagnosed early, we can count as a parent.
No, let it be there. Meena, slide change பண்ணு. Slide change கஷ்டமா இருக்கும். Counsel the parents to come to the hospital, get it treated early. As we discussed, it is the most common consideration anomaly of the change of patient area. They could be left alone, or they could be left palate alone, or they could be combined, left lip and palate. We have that left lip and left lip and palate. Mostly occurs in male. Male predominance is more, but left palate has a more of female predominance. These left as we have seen three bilateral Chinese accent or midline, or they could be associated with other abnormality, or they could be syndrome or non-syndrome. So here we see there is one unique accent left lip. This is left lip plus palate. Lip is also left and palate is also left. Then bilateral left lip is left and that is incomplete left palate. Here we have the complete left palate. So coming to the classification, how do we classify left lip and palate? Very basic classification which was given by our own Indian professor, Professor K. Balakrishnan. So he classified left into three groups. The group one, which involves only the left lip. One is left lip. If group one A is alveolus. If it is involving the bone also, like the bone of the center of the lip, then it is group one A. Two is only the left palate. If it is involving both the group, both the left lip and palate, then it is group three. So, how does it occur? We heard that it is because of the non-fusion of the facial structures. Why left lip? Why some kids will have left lip? Why some kids will have left palate? And why some kids will have both? So we can see from this diagram. Facial development in it has starts at the age of around 40 to 50 of its uterine life. When the development starts, there is basically three processes. One is the frontonasal process. We need them. One is the maxillary and one is the mandibular process. So this is the interplay between the frontonasal and the maxillary process. The maxillary process is lateral nasal and medial nasal. So if this medial nasal, which comes and forms the philtrum, does not meet with the maxillary, then it forms. Yeah. By chance, the maxillary process is parallel place. Please do not use in the center or with the alarm from the medial nasals. If they don't use, this leads to left palate. So this we can see by this week of intrauterine life. That is why we say that by 20th week of intrauterine life, if we are able to see left lip of palate in the USC or MRI or USC, so we can explain the parents whether any syndrome is associated, whether they should continue with the pregnancy or not. So, what leads to non-fusion of these structures? There are some physiological factors. For example, they could be genetic or non-genetic factors. Genetic factors would be some Jesuit Palette syndrome, which is mostly syndromic. Like with the left Jesuit Palette, some other symptoms will also be there. For example, the head has not developed properly, or the fingers are joined, acrotomically is there. So So they mostly involve involvement of chromosomes. Other environmental factors, for example, smoking or industrial smoke, alcohol, uh, nutritional deficiency like folic acid. So that is why we recommend pregnant females or pregnancy also to have folic acid 400 times. And certain drugs like antiepileptics and this steroids can also cause development palate. It can be genetic and environmental factors. And there can be syndromic, non-syndromic association. How do we diagnose left lip and palate before itself? There is something known as pre-later diagnosis in counseling. So this can be diagnosed easily on ultrasonography before 20 weeks. The sensitivity would be some 60%. If it is not diagnosed on ultrasound, we can go for newer methods like fecal MRI and 3D ultrasound. These are used in complex cases where we are not able to find or we have some doubt that their clip of parent would be there in the ultrasound, but we are not able to get it. So this provides very comprehensive images where we can see their clip and parent separately and very clearly. So once during pregnancy, somebody has been diagnosed with carrying left lip and palate. How we handle? First, we have to check whether there were any other syndromic anomalies associated. If we see that the kid is not viable at all, then we can tell them to go for medical abort or surgical abort. But if it is only the kid only has left lip and palate, we have to reassure them that it is totally normal and totally teachable. Left lip and palate can be treated, but they just have to get in touch with us and to remain a constant follow-up. After the call, what all do we see? We have to see the clinical assessment of the patient, whether the airway is patent or not, because palate will interfere with the nose and the oral cavity both. So, if the airway is not patent, we have to go for patent management. Then feeding has to be monitored. There should not be regurgitation and persistent infections going to the brain or the middle ear. And we have to see whether any other anomalies are there or not. In some cases, left palate is associated with retromyopia. So there will be breathing problems. So we have to see, we have to ensure proper airways as a Peary Robin sequence. Peary Robin sequence is the sequence when there is a small mandible, a large tongue, and to accommodate that large tongue, we have the cleft in the palate. There's a small mandible. Here. So, because of the small mandible, they have a bigger tongue. And that bigger tongue to get accommodated, there will be a cleft palate. So these kids have a smaller airway. So they need, we have to see whether that airway is maintained or not. Along with this, we have to keep on seeing the anomaly workup. There could be cardiac anomalies, so exercise must in these cases. Renal anomalies could be there, so we should get the renal function test for the to see and skeletal anomalies can be there. Then that can be instead of clinical examination itself. The sign can be examined and many other senior board defects. And genetic counseling has to be done. So as to see that further their siblings or their kids might not have similar genetic workup. So this requires a multidisciplinary care. There is role of a plastic surgeon who will cause who will repair all these different pallets. Pediatrician has to be seen so that midway is maintained, feeding became controlled. Orthodontist for the uh, and the alveolus. Speech therapist for a good speech and ENT and psychologist. So timeline of the surgical intervention would be lip repair 3 to 6 months. Come to this, let me move. So, proper counseling needs to be given to these left with and their parents. And we can also go for taking or major alcohol moving. Bring the left leg together and cases the procedure of repair. Timeline. What is our major goal in treatment of left leg palate? Major goal is to bring the face, the child face to a normal appearance at a common linear distance. That is, the people not able to comfortable that the kid had left leg or palate earlier, so that they are comfortable socially. So our work starts at age of 1 to 4 weeks. At the age of 1 to 4 weeks, what we do is we go for a pediatric evaluation. We see the feeding evaluation and we see whether feeding can be done to bring the lip and the palate. At 3 to 6 months, what we call the rule of 10. The kid attains the age of 10 weeks and every age of 10 grams per status. And the weight is 10 pounds, more than 4.5 kg. Then we should go for a leg repair. What will leg repair do? It will help in easier attaching of the why we should do leg repair at this age. So that the patient or the kid is able to attach to the network easily. And there is a better cosmetic appearance, aesthetic appearance. And healing of the wound will be better. So scarring will be less. Then coming after that, after the lip repair, we come to ENT and further feeding evaluation. So feeding has to be taken care of. The kid should be nutritionally provided so that he attains a better weight of around 10 to 11 kgs or around 10 kgs, so that they can proceed for a palate repair. And for nasal and the ear infections, we can insert a bromide. So as to drain the any secretions which are there in the ear. When do we do a palate surgery? Palate surgery we do approximately around 9 to 12 months. Why? Because it should be done just prior to the child starts to speak. So that there is the speech developed in a normal fashion. So at 9 months we can do that. Then we go for speech assessment or speech therapy. We will process them for speech. At this age, we come to know whether any deficit or deficit is there in the speech. Operation is and you can go to lastly the tendencies there, the weathers or the finance. So that we can operate and help him attain the speech later on. After that, we go for weather parenting clinical transfer. As I told, at 3 to 5 years. So, and after the speech we have taken care of, the speech therapy will still go on. Along with this, we see how the alveolus or the we go for dental follow-ups. The ortho follow-up. We come properly. Just before the eruption of the canine, that is around at the age of 7 to 9 years. We go for alveolar grafting so that there is proper orientation of the teeth. This grafting grafted from the bone which we can take from the ilex region or the ilex bone. So that proper orientation is achieved. At this point, we can go for it, if we have already done it at the time of left or parallel effect. Then, further we go, like if the patient had retrography, we can go for manual surgery to, get, prove and then, once the child has attained puberty and, he has, gone through puberty and all the basic development has occurred, we can go for a final radiography, checking of the ear, of the nose and the mandible. Sometimes, we go for radiography earlier and then the development, which is basically when, the kid had already attained the age of 9 to 12 months. Because it was, the kid was already nutrition deficient, so that time we could not do the deficit. So first we do the parent effect. Also, in Indian settings, it is important because even if that already there has been repaired, patient is looking aesthetically fine, so there is no need for parent effect. In that case also, we prefer doing the parent first. So in this, we can see the before after this and parent surgery. Then it has, then bilateral second effect. And now it, is not even visible that he had the chest earlier. So the conclusion is, early diagnosis is important with proper counseling that it is feasible. There needs to be a team-based approach, and many, specialists are involved in this. There needs a long-term planning and follow-up. So we should always encourage the patients to keep following up with us. They should not lose contact or not lose hope. And to encourage the family, even when, parents may think that, okay, lip has been done, parent has been done, there is no defect now, but still, speech has to be improved. So this is an ongoing process. And diagnostic treatment and, further, new advancements are coming in this field, which, we can study for better, improved results.
Next போதும்.
Have any doubts you can ask.
Thank you, Honorable members. And now I invite
Have any doubts? You want to accept it? Thank you.
ஸ்லைடு யார் சேஞ்ச் பண்ணலாம் பண்ணிக்கலாமா இது மயோனா இல்ல இல்ல ஜிப்மஸ் மெல்டிங் கிளிப் ப்ராஜெக்ட் Thank you, ma'am, for your elaborate speech and that, very, valuable one. Now I invite, Mrs. Rajeshwari, project coordinator of Jipmas Mentoring Club project. இங்க இருக்க மைக்
Morning. Okay, let's start, sponsoring project என்ன நடக்குது, what we actually do in plastic surgery department. Okay. The operate on the baby. Live operate on the baby. Like, sponsoring on the motto என்னன்னா, every child deserves a smile, every child deserves a friend, every child deserves a future. எதுக்காக, everyone can understand Tamil and English, right? Okay. நிறைய psychological problems இருக்கும் நம்ம children. First issue is they don't have a friend in the school or they'll be bullied every time because they couldn't speak properly, speech will not be proper, and there may be facial deformities. So, first psychological issue is they never have a friend. So, they have given that motto as every child deserves a friend. Okay, now what we see here is the club palette. This is pre and that was post operative. What we do in Jaipur? Jaipur ranks among the top three medical colleges in the country that everyone knows. It provides comprehensive free healthcare to the community based besides maintaining highest standards in our medical education and research. Jaipur is the largest autonomous institute under the Central Ministry of Health and Family Welfare and the Union Territorial Committee. We have achieved a global leader award. 99 have achieved Department of Plastic Surgery have achieved a global award of 2016. And we have an ISO certification also. Basically, Smile is like NGO. It has been started in 1999 in China. In 14 years, become the largest club organization in the world with programs of 80 plus countries. And started in India in 2000. And in Jaipur, we started in 2014. Till now, we have operated 770 patients and we have generated around 2 crore funds. Like for each patient, we receive funds and we spend the funds to the patients and these awareness programs and everything. Department of Plastic Surgery, Jaipur is only the club center in Pondicherry under Smile and like in and around Pondicherry people, including Karaikal, Yana, also come here for treatments. Also cater to parts of Tamil Nadu adjacent to Puducherry. Tiruvannamalai and Kalakurchi are like have the more incidents in clubs. Plastic for club care facilities. We have OPD. This is the OPD 307 that works from Monday to Thursday. And actual OPD is on Tuesday and Thursday under the Dinesh and Mokul. Development and panel counseling services are given in ward as well as in OPD because we have our respiratory office in OPD. So anytime patient can come for counseling, for surgical counseling, feeding counseling, and everything. Project aims to provide the best and latest in treatment of cleft lip and palate for affected patients and promote research in cleft treatments. We have faculties in our department. Dr. Sidoria, Dr. Devi Prasad Mokota, Dr. Dinesh Kumar, and Dr. Priji, who are like taking the surgeries patients. Department of Plastic Surgery also gives speech therapy assessment facilities, and we have nasodoscopy services for club patients in Ward 145. We have well-trained needs for club children. Pre-operative, post-operative management is also available, which is given by nurses and ward and like also PPF, all pre and post-operative advices and counselings. We have done outreach camps and awareness programs and mentorship programs, like almost 5 or more than 5 per year in Jaipur and out, like outreach camps out of Jaipur. Jaipur administration have been instrumental in providing logistic and administrative support for carrying out this important project. We have a contact number to contact, like we give it to the patients for their queries and information. Thank you.
Thank you, ma'am. Now I call upon Mrs. Vijay, Senior Nursing Officer, to deliver strategies to optimize breastfeeding and complementary feeding for children with cleft lip and palate.
Morning, gathered here. First, I would like to thank project director that Mahapatra said, and our CNO ma'am, and SSB nursing superintendent, Pulata ma'am, and deputy nursing superintendent ma'am, Mrs. Devika Srihan ma'am, for giving me this opportunity and for their support and guidance. Thank you, sir. Thank you, ma'am. So actually, I'm very happy to see you all from different disciplines, right? From antenatal, postnatal ward, plastic surgery, and pediatric surgery, so many departments. So you can be comfort and enjoy the session. You can share very well your ideas and suggestions, right? If you have any doubt on the completion of my session, you can very well ask the doubts and thing, right? So the topic given to me is strategies to optimize breastfeeding and complementary feeding for children with cleft lip and palate. Is it necessary to address about optimization of breastfeeding and promotion of breastfeeding and exclusive breastfeeding? Yes, it is necessary. Our country has many advances in many sectors like education, health, agriculture, and space research, but still we are struggling to reach under 5 mortality rate with the SDA, the Sustainable Development Goal of the rate, expected rate is 25 out of 1,000 live birth, but still we are struggling to reach that thing, right? So now we have reached from 36% to 32%, but there is a challenge always. So it is necessary to address about the importance of breastfeeding and complementary feeding. Are you all agree with me? Yeah. What is the WHO World Health theme this year? It was observed on April 7th, right? What is the healthy beginning and hopeful future? So it highlights the critical view on nutrition of maternal nutrition and newborn nutrition for shaping the future, healthful future, right? Beginning, right? So that is the theme, that's for your kind information. We'll move on to our session. Oh. Why optimal nutrition is important for babies born with cleft? Whether without optimal nutrition, is it not possible to undergo surgery? What is the issue in it? Why we have to optimize nutrition for to undergo surgery? What is the need in it? Yeah, you can give a microphone on this. Yeah, what is the issue? Pardon? I'm not getting your point. Yeah, very good. The surgery weight have to be 10 pounds. Yeah, very good. Just give me the date of that. Yeah. So this initiation of surgery will take 1 week. The rule of 10 is applied here actually. So initiation of surgery is only done like the baby has 10 pounds or 5 kgs of weight and 10 grams of hemoglobin and 10 weeks of age, right? So that is the standard thing we need. And also to prevent infection. So these babies born with breasts are more prone to infection. So early surgery can bring down all the complications and consequences related to this infection, right? So early initiation of surgery is very, very important. I will say it is the primary goal, right? And obviously for optimal growth and development, optimal nutrition is important. if you are not done the surgery at the year, at the recommended age, what will happen? You think not only health consequences or health issues, the major issues related is social stigma, right? And the baby, normal baby, இருந்தாலே நிறைய விஷயங்கள் ஆனா பிறந்தா பெண்ணா பிறந்தா நிறைய பிரச்சனை. So if the baby born, think of the situation, if the baby born with the roughly parent, stigma will be there and social exclusion will be there. The baby themselves get isolated from the peer groups, right? So when they are going to schools and the bullying will be there and they themselves isolate from the society. That is the major issue you need to address when coming to this condition, right? And another thing when coming to health issues, speech impairment will be there and hearing problem will be there. So these all are the problems, these are the consequences related to if the surgery is not in recommended age. So if it done at early age, everything will come to its normal. So before going to discuss about the topic, I will interested to discuss an interesting topic. Yeah, importance of first 1,000 days of life. What does it mean? What does it mean? What is first 1,000 days of life? From conception to from conception to 2 years. Second birthday of the child. So this is the crucial period where you have to concentrate on maternal health, infant health, and childhood health. This is about 270 days of pregnancy and 180 days of infancy, and the childhood some 550 days. Totally comes around 1,000 days, right? So it is very, very important to concentrate during this period. This period is very much important to consider maternal health, both maternal health and baby health, right? Yeah. To ensure optimal nutrition to the baby, it is very, very important to give nutritious and balanced diet to the mother. I did say that we are discussing cleft lip is the consequences of malnutrition, right? But I did say malnutrition is the cause for cleft lip and palate. Are you agree with me? Why? Yeah, deficiency of nutrition for maternal nutrition is a predisposing factor for formation of cleft lip and palate. Right? So in this period, antenatally, if the baby, if the family, if the mother have previous history of cleft baby, they supposed to take folic acid 400 microgram. Sorry, before if they have planned to conceive, no, for a second baby, they have to take before conception. They must take 400 microgram of folic acid, and it has to be continued for forthcoming days, right? So that is the recommended dose. And if there doesn't have any history of cleft lip in the baby, or if normally what is the thing? What is the period we start folic acid? In what month? First trimester, second trimester. First trimester, we have to start with folic acid 400 microgram, followed by iron and this thing, right? So it has to be followed. Actually, folic acid function is similar to tuberous effect, but the study says that an American research study says that by taking folic acid antenatally, we prevent the incident by 33 to 40%. It's good thing, no? If it fails, if the mother fails to take the folic acid, then the body double. The research emphasizes the importance of folic acid, right? So, if as a healthcare worker and we nurses, we are directly giving care to the patient, you have to emphasize the importance of folic acid to the antenatal mothers, right? We move on to the our so the topic given to me is strategies cost. In this, we are going to see the money, everything you'll be knowing, but some of the specific things which is exclusive for babies, I'm going to discuss here. I'm not going to give you the lot and lot new things, right? So I'm going to discuss about benefits and challenges of providing breast milk to infants with blood and understanding breast milk production to enhance good breast milk feeding. We have to know what are the factors influencing and inhibit the enhance and inhibit in the milk production. And recommendation of molecule positioning and tube-based feeding milk breast milk substitutes. Right? One by one, we'll see. First is can you share what are the benefits for maternal and infant common benefits then? Can you give mic to Sina? Any benefits here I can take. So many benefits are there, no? N number of benefits are there for both maternal benefits are there and then infant benefits are there. Baby benefits are there, no? You can share. Or you can say you have more experience than my because you are the older school of nursing, new school of nursing, no? Yeah, very good immunity. Brain development. Yeah, very good brain development. From that side. And nutrition. Bonding with the baby. Bonding, very good bonding. Free of infection. Yeah, infection, preventing infection. So these are so many numbers, and there are many things to discuss about that. We cannot compare this milk with any feeding, right? This is the gold standard of feeding. Are you agree with me? Breastfeeding is the gold standard of all the feeding. So we cannot compare this feeding with all the feeding. So coming to our babies born with plus what are the benefits when you are providing breastfeeding to the babies? So it helps and strengthen the muscles around the face and mouth to promote better speech of the infant growth, right? So the first thing is the problem is latching. We'll be discussing in forthcoming slides. Latching is the major problem as the baby is having plus. And another thing, the speech impairment, as we have seen the consequences of health consequence, speech impairment will be there. So if you initiate breastfeeding and promote breastfeeding for babies, it will due to latching and sucking, the muscle around the oromaxillary it will get strengthened and it will enhances the better speech as the infant grows. So it is very much important to initiate breastfeeding to the babies born with plus. And the breast is more flexible. It's obviously, if you give silicone nipple also, if you have a advanced nipple also, will not be more comfortable when comparing to the natural made, masculine breast, right? It will give good sealing to the baby which has baby is having plus. An infant has more control over positioning and milk flow. If you give bottle feeding, there is a problem with this thing, holding, positioning, everything. If it is a natural thing, no need of preparation, and the baby if you are encourage modified positioning, you can ease the baby to get easy flow of milk, right? So that is the major this thing. And the natural substance less irritating. Yeah. For your kind information, what is the immunoglobulin abundantly present in human milk? IG? Very good. IgA, what is the function of it? Immunity, right? So the one the immunoglobulin antibody which is present in human milk, tears, and this in saliva is a IgA immunoglobulin antibody. It has the primary role is a mucosal immunity thereby it protects the baby. Mucous layer of organs like nasopharyngeal, right? Nasopharyngeal, respiratory. What is the discussion going on here? Nasopharyngeal and VA. So that is that way is prevent the infection in that regions, right? And also as the thing, it is a natural substance, not a formula thing. It's less irritating to the baby. Why? Why less? The baby often get baby aspirate the milk will come out to the nose. So it is very good to give breastfeeding to these babies, right? And decreases ear infections and respiratory infection. Obviously, as I told you earlier, breast milk has the capacity to prevent the infections, all infections, but this infection, 80% of the infections, ear and respiratory infections can be reduced by giving breastfeeding. This is the research, one of the research reveals that 70 to 80% of the ear infection and respiratory infection can be reduced when you are providing breastfeeding to the baby. So it is very much important and provide the closeness above all the things, this is very, very important for the babies born with this condition, right? So intimacy, closeness, emotional bonding, or this thing what we are nowadays RMC in what is the two thing? Those who are from antenatal, postnatal, huh? So create intimacy and skin to skin contact. Glands of mother and skin, grooming process. So glands of mother is very, very important for this baby to promote that the baby will feel that we are in the support of mother. So already baby, you don't think that the infant doesn't have any emotions or this irritation or many all things will be present for baby also. That discomfort will be felt by the baby. I am unable to get the milk. So you think of the situation of the baby, right? So if you give good bonding, emotional support, skin to skin contact, it will give the psychological support that by it enhances the mental development of the baby in forthcoming years, right? Are you agree? Yeah, okay. Any doubt for this? We want the, yeah. As I told you, we are talking about enhancement, optimization, exclusive breastfeeding. We need to know how the mechanism of breastfeeding takes place, right? It is not, and we all know the use it principle, right? If you touch the breast, the milk will get produced. If you don't touch the breast, the milk will not get produced, right? So that's what we are emphasizing mother for this kind of this condition babies. And regardless of direct breastfeeding, you need to put the baby on mother's breast to promote good breast milk production, right? So that is very, very important. And as you all know, prolactin is the hormone and milk production. The oxytocin is for milk ejection. And in knowing. Yeah. Is direct breastfeeding possible for babies born with classical infant palate? Yes or no? Who are accepting? You are telling yes. Raise your hands. Raise your hand. I have to test. How many of you? 1, 2, 3, 4, 5, 6, 7, 8, 9. So remaining 20 persons or that don't want to give direct breastfeeding. Mothers will club and yeah, for the kind information, direct breastfeeding is advisable for all type of clubs, right? So that is what this session has been arranged. There is a controversy and confusion and so many things are going to be discussed with the pediatricians and the surgeons and nurses. So direct breastfeeding is advisable for the baby born with cleft lip and palate. So for cleft there is lip, there is no issues. And coming to palate, there is an issue, but that thing can be modified with some of the things, right? So we are going to discuss in demonstration class. So please remember direct breastfeeding need to be encouraged and emphasized with babies born with cleft lip and palate. And how to give? Yeah, we are talking about the exclusive breastfeeding, optimization of breastfeeding. Then how to give breastfeeding to the babies? Can you direct breastfeeding and indirect breastfeeding? Can you find any difference over it? Any difference over it? Direct breastfeeding and indirect breastfeeding? What is direct breastfeeding? Directly from the breast. Then what is next? So direct breastfeeding, if you are giving breast milk directly from the breast, it calls an indirect breastfeeding, direct breastfeeding. And if you extract the milk from the breast and the use of any appliances you are giving, that is called as indirect breast milk feed. Right? Breast milk feed. Okay. So this is the direct breastfeeding, as I told you earlier. For unilateral club, direct breastfeeding very well you can offer, right? There is no doubt about it. And indirect breastfeeding also, actually the objective is here is we don't want to waste even a drop of breast milk because it is very important for this condition babies, right? So we don't want to waste even a single drop of breast milk. For that only, if it is not possible to give direct breast milk, breastfeeding to the babies, it is advised to collect the breast milk through any appliances, either with the hand expression or with machines. You can extract the breast milk and you can very well offer to the babies. So this thing will be discussed in demonstration class. I don't want to waste your time. Understanding breast milk production, and this is the assignment I am giving to you people. I will be asking this thing. We will have discussion when in the during the demonstration class. What are the factors which increases breast milk supply and production, and the factors increases the mother's milk production and supply? You can share your knowledge, right? And coming to the challenges of breastfeeding for infants with clip and parallel. Yeah. Accepting baby with the club itself is a major challenge. Are you agree with me? Many places in India, in primitive villages and rural, where the start with parenthood, family issues and social stigma, so many problems. So when we receive patients in plastic surgery, we came to know so many traumatic history of the mother will tell. The mother will be left alone after gave birth to this type of babies, right? So there are many challenges when you think about the baby, the mother to give feeding to this type of babies, right? So difficulty in forming a time seal around the areola. This is the first problem, right? The good latching is very important to get the milk, right? For free flow of milk and also for secretion of milk. Here, the baby cannot able to hold the areola to make a seal around the breast, right? That is the primary challenge that needs to be addressed when you go challenges faced by the baby, right? And another thing, difficulty in building negative pressure. Once the negative pressure created in the oral cavity, only the bacteria create and the baby will get the easy sucking of milk. So there is a flap in the palate. How could the baby create negative pressure and where can we go and get the vacuum? So that is the second challenge. Right? And these are non-rhythmic. So due to this problem, there will not be a non-rhythmic that will not be there. And following movement care. Yeah. Actually, when practically if you see that baby, no, baby will easily get tired and satiated. Easily a baby will get satiated. So because half milk will be in the stomach and half of the air will be there. So during this difficulty swallowing, so gagging, so like this, no, it will swallow milk with the air. So easily the baby will get satiated and tired also. So here you concentrate on core milk and hind milk present. Core milk and hind milk. So both the milk is important for baby. But the baby is getting so tired that sometimes baby fails to have the hind milk. Why both the milk are very important? Core milk pinches the thirst as it contains more lactose than fat, and the hind milk contains more fat than lactose. It gives satisfaction to the baby, right? So both the milk has to be given. If the baby fails to take hind milk, better it can extract the hind milk from that breast and can be fed to the next feeding. Are you getting the point, right? So don't waste that hind milk. Has to be provided that next feeding and start with the core milk feeding and the next breast. Okay. And milk leaking out of the nose. So you're not actually no need to get panic about that thing, but usually the mother will get panic. But if as a health worker, you should give positive reinforcement, build confidence. This is not harmful to the baby, but frequent choking and gagging must be avoided while giving proper positioning to the baby. Right? And make tired more easily and not long enough to get there. And this what I was discussing, no? The baby உடனே அவங்களால அந்த சக் பண்ணி நார்மல் பேபிஸ்க்கே ரொம்ப கஷ்டம் இல்ல அது குடிச்சு எடுத்து குடிச்சு அவங்க டயர்ட் ஆயிடுவாங்க ஸோ இந்த பேபிக்கு நீங்க யோசிச்சு பாருங்க அவங்களால வேக்யூம் கிரியேட் பண்ண முடியாது சக்கிங் ப்ராப்ளம் latching problem so they feel difficult to get the hindwing so but it needs to be addressed. How to overcome the challenges? Yeah. The challenge has to be overcome for better initiation of breastfeeding, optimization of optimal growth and development of the baby. Modified position will be discussing and create good latching will be discussing and plus good latching how to create good latching I will explain in demonstration class and press actually the breast has to be pressed towards the mother's chest. And compression has to be given to the baby to easy flow of milk and compress the breast during breastfeeding and frequent feeding as the baby get iron doesn't earlier no so it prevent the hind milk intake of food. Very frequent feeding here is advisable and burping frequently. Yeah, burp frequently. This is very much important to prevent aspiration and regurgitation. So these are some of the possible way to overcome the challenge. We'll be discussing detailed demonstration. What are the modified positions for infants with cleft? Various feeding positions that work best for infants with cleft lip and palate. So the first thing is modified cradle hold position. And another thing is football hold and rugby hold position. And another thing is stance and hand position. Are you aware of these positions? Debating from here. Are you aware of these positions? Have you tried ever? So these are some of the positions. This is the modified football hold and rugby hold. This is interesting. Actually, for your easy understanding, I made this. This is the rugby ball. This was rugby ball. Like this, you have to hold the baby. I'll explain you demonstration. Right? This is the for bilateral plus you can advise this position. Advantages and disadvantages will be discussed in demonstration class. And dance and hand hold position. This is for good latch. That is but that dance position, no. Dance to western dance is how they hold the partner like this, no. So like this, dance and hand hold position. This is the position and show the image. Like you are hold the baby. And another thing is modified cradle hold or cross cradle hold position. In a normal position, what you are applying for to feed the baby is a cradle hold position. Are you very well know about it? You know, the modified cradle hold position, for the some of the modification will made with the easy flow of food. That is modified cradle hold. These are but the most important position which is more recommended for flat babies is dance and hand hold position. So then only we go with this hold position and modified cradle hold position. Modified cradle hold position for unilateral you can apply that position. What I meant. Any doubts? Any doubts over that? Take a break. Relax yourself. This time. Getting bored. And modify trading hold position. So for unilateral flux, you can apply this position. I will demonstrate it for coming right? And yeah. This is the interesting part actually. Always there will be an argument with the nurse and the mother. The mother always telling postnatal what she will say. And some mothers know you can't imagine. Some mothers will go postpartum depression. They think that I'm not enough to feed the baby, right? So you can show these pictures. So by the day one, the baby's capacity of holding milk is 5 to 7 ml, and then by day 3 it's 22 to 27 ml. By 1 week 45 to 60 ml, and by 1 month it is 80 to 150 ml. And this is the diapers, right? To observe for sign up, sign up, sign up. Very good. Dehydration. So by day the baby will get one diaper. By day 3, three diapers, and by day 7, 6. And followed by it depends upon the baby's the digestion capacity, and it based upon the growth and development of the baby. We want to worry about the thing mother will take care. So this is also an interesting picture. Actually, they are comparing the amount of milk with the fruits. By day 1 cherry, you can compare this fruit with our Indian local fruits, I think, cherry. And by day 3 with apple, this is the walnut, I think so. And then another day 7 apricot, and by 1 month the size will become a 1 egg size. Right? So this is interesting. Okay. Are you clear about this? Any doubt about this? No, no. So that's how this picture the mother who are making oral milk here and not getting the breast milk now. And again, coming to the infant feeding use rate, this is based on the demand feed or based on the infant use rate. These are all the early things, that is the communication produced by the babies by using head, face, eyes, hand, body. So all the gestures will give you the cues that I am very hungry. So the early cues is traveling and mouth opening, and this rooting reflexive breather, and it cues actually stretching will be there, and increasing movement and hand to kuduklana I as a part. So these are some of the cues related with infant. So based on the cues you need to give feeding to the baby, right? And again, baby is everything got done. I am okay. Post feeding cues. So these are some of the cues, like infant open fist and arms slightly close body and false sleep. Okay. Points to be remembered. So we are discussing about the optimization of breastfeeding. What is the mother condition to feed the baby? This is very, very important. Already mother is under stress, denial will be there, frustration will be there. So that needs to be addressed before you are giving. This is the position, you have to adapt this position. This is the position, it is good for your baby. Please don't stress mother to take any sort of this things. First go with first assess the maternal condition and baby condition, then you start advising your things, right? What we have learned in previous slides, right? So counseling mother is very, very, very important. If you fail to counsel the mother, you fail to give exclusive, we will not attend the success rate of exclusive breastfeeding. So counsel the mothers, so this father from social worker or this, but here we are only doing build confidence. So I am not going about this, but people might be knowing very, very well about knowing the counseling and guidance, how to counsel and guide the mother with this condition. So build confidence here, encourage mothers to provide counsel mothers and the likely and realistic breastfeeding expectation. This is very important, right? So these are the expectation. Your mother, baby may get the milk may come out through the nose. So you need not worry about the things. These are some of the expectation need to be discussed with the mother. And do not confuse challenges. This is very, very important. Already the mother is under stress. Please don't confuse the mothers. What are the positions and the exclusive breastfeeding recommendations by WHO and any to the mother. Right? So be patient to the mother. Whatever position is comfortable to the baby, the mother, and also it depends upon the individual baby concern. Right? It depends on the type of the cleft or comfort of the mother. It may get deeper. Right? And feeding will take place as now different positions. Peer support is very, very important. You you connect the mother with the mothers, those who are having the same issues or those who have gave birth to the same condition of baby. So they can share their ideas and views and this thing, discuss can be linked to the baby. This is very, very important and WHO recommends 6 uh, counseling session. So I will say whenever you get the chance to meet the mother, start give counseling. It will take 2 to 3 minutes only. Just start give counseling. Giving counseling to the mother to build confidence, right? So these are some of the recommendations given by the WHO: antenatal period, perinatal period, neonatal period, early infancy, 6 months and after 6 months. These are some 6 counseling has to be given to the this mother, right? Okay, the breast milk expression and storage will be discussed in demonstration session. And these are some of the feeding appliances. This is an ethic of action. Okay. We'll be showing you a demonstration plan. Please don't ever recommend bottle feeding. Already babies are prone to infection. Yeah. Please don't introduce infection from yourself. So please don't recommend bottle feeding for any kind of bottle feeding. Now the new recommendation given by Indian Pediatrics Academy and Smile Train, they are not at all advising this thing, bottle feeding to the baby. You have to give direct breastfeeding or otherwise go with the extract and give as I show you that no feeding appliances you can make use of that. Yeah, we are talking about breast milk. Think the situation, if the mother is not getting enough breast milk, you can go very well with the formula milk. The first recommendation given by WHO is formula milk. And no cow milk is not recommended below 1 year of age. Please remember that. And if the family is not affordable, means you can go very well go with the pasteurization milk locally available on that zone. And and for breast milk substitutes and breast milk sharing also you can breast milk banks are there now you can get milk from that according to their new protocol. The intake carries some huge amount of milk. This is the age old tradition our palade very safe and cheap, right? Yeah. We have completed our this thing, breastfeeding. Till now, any doubts? You have any doubts? You can very well ask. Now we are moving to more complementary feeding. Can we introduce complementary feeding before surgery? Before surgery, this is advisable? No. Yes. How many of you know? How many of you? Yes. Raise your hand, please don't. Can we introduce complementary feeding by the age of 6 months for this condition babies? How many of you yes can please raise your hands? We can very well introduce complementary feeding to the baby. No issues in that. Only thing is the food will may come out through the nose, but you need not worry about the thing. No need to panic about the things. It can be the baby let her learn how to modify and swallow the things without regurgitation and aspiration. So very well you can introduce. Actually, by 6 months, as Madam told, by 6 months, with the 3 months, the lip surgery, the lip repair may get done. By 6 months to 1 year, the palate also will get done. We suppose if the baby is malnourished, underweight, if it's not possible to undergo early initiation of surgery, you can very well start complementary feeding by the age of 6 months, right? And I'm not going to join in detail about complementary feeding, but because it will take another 1 hour to discuss about the complementary feeding and the whatever the recommended dietary allowances, I'm not touching that part. That just I want to give some important points related with our babies born with this condition, right? Points to be remembered by giving complementary and weaning food. Introduce one food at a time. யாருக்கெல்லாம் இன்னைக்கு குழந்தை இருக்கு ரீடிங் வச்சு கொடுத்துட்டு இருக்க குழந்தைங்க கை கொடுங்க கை கொடுங்க யா நீங்க எப்படி இன்ட்ரோடியூஸ் பண்ணீங்க yeah mashed potatoes okay. Yes, we first start with mashed potatoes. Okay. Yeah. The first thing the introduction must be a cereal based food, right? Then go with the pulses, vegetables, and fruits. The first thing will be the cereal based. In our area, in Tamil Nadu and South, we introduce what will introduce like rice and this, from the porridge and all we'll go with ragi, right? So that is the thing. In north side, we'll go with wheat based food, right? So that is the cereal based food is the primary food you have to introduce to them. If the baby have allergy with that fast food, what will have to be done? Is that food and introduce new type of cereal, right? So then you check for whether baby is getting allergy or they go with that food, right? And diversity of food. Diversity of food means what? Different types of food. Different types of food need to be included for energy dense foods, protein rich foods, vitamins, minerals, oils, fats, everything need to be included in the complementary food. And locally available foods. Don't go with the fruits which having imported from what are the in our market, some different kinds of foods. So don't go with the fancy fruit. They make the crossover banana and apple and orange, everything will be made out of it. So out of 5 out of 10 locally foods, you can is that. So what is the importance? You will get balanced thing of all the vitamins and minerals. That is the main food, right? So that is the diversion of food and 5 out of 10 locally. That locally available food is genetically made to get digested with that food, right? So oats is very familiar. Nowadays, oats is very famous, no, in weight reduction. But then to take rice, every vitamins must be avoided, right? And energy, these foods, texture and taste is very important, and quantity doesn't matter. Yeah, this is very much important for our babies. The problem is with the regurgitation and aspiration. So never mind with the quantity doesn't matter here. Quality matters, right? How to increase the quality? If you are giving 1 cup of ragi porridge, no. You please think how to increase nutrition and the energy and protein with that 1 cup of ragi. That is very, very important for all babies. For all the babies, it is recommended by WHO and homemade food. This is very, very important. Don't go with Cerelac. So many things are available in market. Please don't go with that. All are made with only wheat flour. and so many additives, right? Diversity of food, as you told, different types of food. And how to increase nutritious value of food. We are telling about to increase the nutritious value of food. No. Now WHO and the Indian Academy of Pediatrics now recommending to add jaggery and ghee and oil to the complementary feeding. What usually our mother and grandmother there is no doubt in it. They now என்ன செய்வாங்க பருப்பு சாதத்துல நெய் போட்டு தான் கொடுப்பாங்க இல்லையா? That actually increases the energy and also calories to the quantity you are giving to the baby. So for your kind information, 1 spoon of ghee will give you 50 kilocalories. And 1 spoon of jaggery will give you 20 kilocalories. This is for some introduction only. We need to be discussed lot of that to discuss this. And this is what is this? Germinated seeds or what is the use of the what is the benefits when you get protein will be rich, all the vitamins and minerals will be there. The double will be the nutrition value will be double, and the main thing is when you are germinating or sprouting the thing, no, the complex carbohydrate will be that complex structure, no, it will be modified into a 6 glucose form, and the protein also will be eased to the digestion of the baby. And it decreases the phytic acid content in the food. Thereby, it increases the bioavailability of nutrition content in the food. Are you all agree? So, germination of this being sprouting is very, very important. Nowadays, in Anganwadi and we are demonstrating mothers how to prepare a green food in home base, like home base. So actually sprouting, sun dry it and grind it and cook and give to the add ghee or jaggery to that powder and give to the baby. With nutrition, no? So very easy to do. So these are some of the benefits. These are some of the tricks to increase the nutritious value of food, right? And how to increase value, as I told you earlier, we are going to give this is a small example I am giving you for your easy understanding. This is this idli is made with rice bag. Normal idli, one portion will carry some 30 gram of portion. You please remember, if this thing, and this idli is made with moong dal. Modality, same quality was same quantity only. The quality differs, right? So 30 gram portions of rice batter will give you energy of 100 kilocalories and protein of 3 grams. And if you compare with this thing, moong dal will give the same portion only. One portion of idli will give you energy and energy more on the same only. But the protein, you see the protein. The quantity need to be increased with the same quantity of the food. Are you getting my point? This is for your time reference only I am giving. You can go with the recommended dietary allowance given by Indian nutrition scheme. So this can be emphasis mother to increase the quality of food. And textures and readiness. And coming to textures and readiness, no, too watery food are not advisable for babies with unprepared reluctant palate, right? Unprepared palate. So the thing is not too watery or too hard. Should be in a that's எப்படி சொல்றது அந்த சாஃப்ட் நம்ம குழம்பு கொடுப்போம்ல ஸ்பூன்ல வச்சுன்னா ஊத்தக்கூடாது கீழே அந்த மாதிரி ஒரு ஸ்டேஜ் தான் நீங்க வந்து நம்ம பேபிஸ்க்கு வந்து பிஃபோர் சர்ஜரி வந்து நம்ம வந்து அட்வைஸ் பண்ணணும் சரிங்களா? So these are some of the sicker can take puree foods and the granola can take mashed foods and diced foods can be taken by the doctors. Yeah, what is expected on feeding? As you all know, as we discussing from morning onwards, regurgitation, aspiration, coughing, food coming to the mouth. Need not worry about that. And sneezing, the child will nicely sneeze, which helps to clear the nasal passage. So sneezing is good for this condition of babies. Dealing with nasal regurgitation, please don't get panic. Tell the mother, don't get panic with that. Remain calm, use neutral words and start with cup feeding. Cup feeding is recommended for our babies with unrepaired palate. And use a sort of cleaning is needed, and children will learn. Yeah, that's what I'm telling. Children will learn how to manipulate each texture around their fluff to limit the nasal regurgitation. Once you start complementary feeding with unrequired fluff also, they learn how to swallow the food without regurgitation, right? So, with allow an infant tongue slurp milk out of what is slurping? What is slurping? உறிஞ்சு குடிக்கிறது. புரிஞ்சு குடிப்போம்ல. இப்படி ஊத்துனா குழந்தைக்கு ஆஸ்பிரேட் ஆயிடும். சோ பேபி வந்து இப்படி வாய் வச்சு சப்பி குடிக்க நீங்க வந்து அலோவ் பண்ணணும். அந்த மாதிரி கொடுக்கும்போது நீங்க ஏதாவது ஃபார்ம் ஆஃப் மில்க் ஏதாவது கொடுத்தீங்கன்னா. And if pumping is not listening, thicken liquid by adding a small amount of uric fluid. இப்போ நீங்க வந்து ப்ரிப்பேர் பண்றீங்க ஒரு காம்ப்ளிமெண்டரி ஃபீட், அது தண்ணியா போச்சு இல்ல கஞ்சி ஏதோ கூழ் ஏதோ பண்றீங்க, தண்ணியா போயிடுச்சுன்னா you can very well add, as she said, few of the mashed potatoes or vegetables, carrots or apple boil பண்ணி அதை நீங்க mash பண்ணி அந்த அதோட நீங்க சேர்த்து you can make the food more thicker for easy swallowing of the baby. And finish the feeding with a small. This is very important. For each feeding, you need to give plain water to clear the oral passages. And supplements, yeah, very well for as low birth weight baby and preterm baby, supplements are advisable. It depends upon the pediatrician and the weight of the baby. Yeah. So while giving feeding, complementary feeding, it is very important to concentrate on food and hand hygiene, and follow-up is very important. Record keeping and monitoring is very important, and nutrition assessment will be discussed by Madam J. Lakshmi in the forthcoming session. Okay. So regardless of, I request you all, regardless of success rate, please, initiation of breastfeeding is very important for this kind of baby. Please remember in your mind, success rate is not a matter. Initiation of breastfeeding and optimization of nutrition to the baby born with cleft and palate is very important. So please help the baby to help the child on their journey to your new smile. Right? Are you? I mean, huh? Okay. So this is what I am come. Finishing my session. If you have any doubt, you can very well ask me.
Thank you, ma'am, for your wonderful speech. Now I call upon Mrs. Apatna, orthodontic technician, plastic surgery. She will deliver nasoalveolar molding.
Hello, good morning. Myself Apatna, orthodontic technician. இப்போ இங்க நான் ஏன் நிக்கிறேன்னா என்னோட டாபிக் வந்து ஆர்த்தோடான்டிக் அப்படின்னு கேட்கும் போதே உங்களுக்கு என்ன மைண்ட்ல ஓடும்னா சம்திங் ரிலேட்டட் டு டீத் அப்படிங்கிற ஒரு பாயிண்ட் தான் எனக்கு வருது. இல்லைன்னா ஓரல் ஸ்ட்ரெச்சஸ் அப்படி எனக்கு வந்து நேசோ ஆல்வியோலர் மோல்டிங் அதுதான் என்னோட டாபிக். அதாவது இந்த கிளப்ஸ்லிக் பேரண்ட் பேஷன்ஸ்க்கு வந்து நாப்ங்கிற அந்த ஒரு அப்ளையன்ஸ் வந்து எப்படி நம்ம போட போறோம், அது எதுக்காக யூஸ் பண்றோம், நம்ம கிளப்ட் பேபிஸ்க்கு எதுக்கு யூஸ் பண்றாங்க, அப்படிங்கிற ஒரு டாபிக் தான் நான் எடுக்க போறேன். ஆல்ரெடி சிஸ்டம் வந்து கிளப் பேலட் என்னது இல்ல கிளப் லிப் அண்ட் பேலட் என்னது அப்படிங்கிற டாபிக் ஆல்ரெடி எடுத்துட்டாங்க அவங்க. அதனால நான் அதை மறுபடியும் பேசி உங்களை போர் போர் அடிச்சுக்கல. ஃபர்ஸ்ட் ஆஃப் ஆல் நீங்க இந்த போட்டோ நல்லா பாருங்க, இதுலயே உங்களுக்கு நல்லா தெரியும். ஃபர்ஸ்ட் போட்டோ வந்து மேப் போடுறதுக்கு முன்னாடி ஒரு குழந்தை எப்படி இருக்கு, ஒரு இன்ஃபன்ட் வந்து நம்ம கிட்ட வரும்போது எப்படி இருக்குங்கிற போட்டோ தான் இது இருக்கு. செகண்ட் போட்டோ பாத்தீங்கன்னா உங்களுக்கு தெரியும் அந்த லிப் கேப் வந்து எவ்வளவு, எந்த அளவுக்கு சர்ஜரிக்கு முன்னாடியே எந்த அளவுக்கு அது கம்மியா இருக்குங்கிறது உள்ளே பார்த்தா நல்லா தெரியும். இப்போ நேசோ ஆர்பியால மோல்டிங்கிறதே நம்மளோட லிப்போட அந்த கேப் எந்த அளவுக்கு, அந்த உதடு பிளவு வந்து எந்த அளவுக்கு நம்ம சர்ஜரிக்கு முன்னாடியே வந்து கம்மி பண்ணிக்கலாம் அப்படிங்கறத நம்ம நேம் போட்டுட்டு நம்ம ட்ரை பண்ணுது. அதுவுமே இல்லாம அந்த நோஸ்ட்ரில்ஸோட ஷேப்ஸுமே நீங்க பார்த்தா நல்லா தெரியும். இதுல வந்து எப்படி இருக்கு, அதுவே வந்து நேம் போட்ட பிறகு எப்படி இருக்கு அந்த குழந்தையோட நோஸ்ட்ரில். ஆனா சர்ஜரி இன்னும் பண்ணல. அதுதான் நம்ம நேமோட அந்த ஒரு பாயிண்டே வந்து அப்படிதான். நம்ம நேம் அப்ளைன்ஸ் போட்ட பிறகு குழந்தைய வந்து சர்ஜரிக்கு முன்னாடியே வந்து எப்படி நம்ம ரெடி பண்ண போறோம் அப்படின்றதுதான் இந்த அதோட பிரின்சிபிளே என்னன்னா, இப்போ வந்து நம்ம கிட்ட ஒரு இன்ஃபென்ட் வர மாதிரி இருந்துச்சுன்னா அந்த குழந்தையோட ஓரல் ஸ்ட்ரக்சர்ஸ் ஃபுல்லாவே நம்ம இம்ப்ரெஷன் எடுக்க போறோம். அந்த நெகட்டிவ் இம்ப்ரெஷன் எடுத்துட்டு அதுலதான் நம்ம வந்து ஒரு கிளிப்பு ஒவ்வொரு குழந்தைக்குமே அந்த குழந்தையோட அளவுக்கு ஏற்ற மாதிரி நம்ம கிளிப் ரெடி பண்ணி கொடுத்துட்டு அதை வச்சுதான் அந்த குழந்தையோட ரீஷேப்பிங் லிப்புக்கானாலும் அந்த நோஸ்ட்ரிலோட ஷேப்பா ஆனாலும் சர்ஜரிக்கு முன்னாடியே அதை வந்து இந்த மாதிரி கரெக்ட் அலைன்மெண்ட்ல கொண்டு வர்றது நம்ம இந்த மாதிரி அளவு இந்த பிரின்சிபல் யூஸ் பண்ணி தான் நம்ம பண்றது. பிமேம் அதாவது ப்ரீ சர்ஜிக்கல் மேம் அப்படி அது என்னன்னு பாத்தீங்கன்னா, நான் முன்னாடி சொன்ன மாதிரி அந்த சிவியரிட்டி, இப்ப சர்ஜரிக்கு முன்னாடி வந்து நம்ம குழந்தைய பார்க்கும்போது அந்த கேப் வந்து எந்த அளவுக்கு பெருசா இருக்குது, அது வந்து மேம் போட்ட பிறகு எந்த அளவுக்கு சின்னதா மாறிடும் அப்படிங்கிறதா மேம். அப்புறம் கோலமெல்லாம் பாத்தீங்கன்னாலும் நம்மளுக்கு நல்லா தெரியும். நம்ம ஃபர்ஸ்ட் காமிச்ச போட்டோலயே நமக்கு நல்லா தெரியும். அதாவது அந்த கோலமெல்லாம் லென்த் வந்து சின்னதா இருக்கும். பேலஸ் இருக்கிற ஒரு குழந்தைய பார்த்தாலுமே நம்மளுக்கு நல்லா தெரியும் அந்த எங்க இருக்குன்னே நம்மளுக்கு தெரியாது. அந்த மாதிரிதான் இருக்கும். அந்த மாதிரி குழந்தைகள்லாம் இந்த நேம் டிவைஸ் நம்ம போடும்போது நல்ல அளவுக்கு அந்த கோலம் லென்த் வந்து நல்லா பெருசாகி சர்ஜரி பண்ண பிறகு கரெக்டா நம்ம அந்த மாதிரி ஒரு குழந்தைக்கு கிளப் இருக்குதுன்னு தெரியாத அளவுக்கு நமக்கு சேஞ்ச் பண்ண முடியும். அப்புறமா பேசிக்கும் யூட்டிலைசேஷன் ஆஃப் மேம் அப்படிங்கறத பார்க்கும்போது இப்போ இந்த ஜிப்மரை பொறுத்த வரைக்கும் ஒரு குழந்தை என்கிட்ட வரும்போது, அதாவது ஒரு ஓர்த்தோட டெக்னீஷியன் கிட்ட வரும்போது நம்ம கேட்கிறோம் என்னைக்கு டெலிவரி ஆயிடுச்சு, எங்க டெலிவரி ஆனது அப்படிங்கறது கேட்கும்போது நிறைய பேர் வந்து ஜிம்மர்லயே டெலிவரி தான் ஆயிடுச்சு. ஆனா வந்து வரது வந்து 1 month கழிச்சு. ஏன் கேட்டீங்கன்னா நிறைய சிஸ்டர்ஸ் இல்ல டாக்டர்ஸே வந்து நீங்க வீட்டுக்கு போங்க, ஒரு 3 months கழிச்சுட்டு பிளாஸ்டிக் சர்ஜரிக்கு போங்க, அவங்கதான் இந்த சர்ஜரி பண்றாங்க அப்படிதான் சொல்லி கொடுக்குறாங்க. ஆனா அது வந்து பெரிய ஒரு தப்பு. ஏன்னா அந்த டைம்ல குழந்தைங்க வந்துருச்சுன்னா எங்களால எதுவுமே பண்ண முடியாது. ஏன்னா குழந்தைங்கள அந்த நமக்கு மேம் போட வேண்டிய டைமிங்கே வந்து ஆல்மோஸ்ட் முடிஞ்சிருச்சு. அந்த 3 monthsக்கு அப்புறமா குழந்தைங்க வந்து எங்களுக்கு எதுவும் பண்ண முடியாது. சர்ஜரி பண்ணலாம், தாராளமா சர்ஜரி பண்ணலாம். மீதி வந்து நியூட்ரிஷனை பத்தி இல்ல ஃபீடிங் அட்வைஸ் அதெல்லாம் தாராளமா பண்ணலாம். ஆனா இந்த ஓர்த்தோடானிக் அந்த ஒரு செக்மெண்ட்ல இருந்து நம்ம பார்க்கும்போது எதுவுமே குழந்தைக்கு பண்ண முடியாது. அப்படி பண்ணாதான் நம்மளுக்கு வந்து சர்ஜரிக்கு முன்னாடியே குழந்தைய வந்து இந்த நான் போட்டோஸ்ல காமிச்ச மாதிரி நம்ம ப்ரிப்பேர் பண்ண முடியும். இப்போ வந்து பாத்தீங்கன்னா நம்ம இப்ப ஒரு குழந்தைங்க வரும்போது, அதாவது பிறந்த நெக்ஸ்ட் டேவே வர முடியும்னா அது வந்து பெஸ்ட். அப்பதான் நம்மளுக்கு கரெக்டான இம்ப்ரெஷன் எடுத்து குழந்தைக்கு நேசோ ஆல்வியால் மோல்டிங் வந்து கரெக்டா பண்ண முடியும். இப்போ இங்க காமிச்ச மாதிரி 0 to 1 weekல வந்து குழந்தைங்க வந்தீங்கன்னா ஃபர்ஸ்ட் நம்ம இம்ப்ரெஷன் எடுக்க போறோம். குழந்தைக்கு வந்து எந்த அனஸ்தேஷியாவும் கொடுக்காமலே நம்ம இம்ப்ரெஷன் எடுத்துட்டு, அதாவது ஒரு சர்ஜனோட பிரசனோட தான் நம்ம இது பண்ண போறோம். ஆல்வியோலஸ் மோல்டிங் பண்ணிட்டு நேசல் எக்ஸ்டென்ஷன் கூட நம்ம கொடுக்கலாம். அதெல்லாம் நான் நெக்ஸ்ட் போட்டோஸ்ல காமிக்கிறேன். அப்புறம் வந்து 1 to 2 வீக்ஸ்ல வந்து பிளேட் கண்டிப்பா நம்ம இன்சர்ட் பண்ணி தான் ஆகணும். இப்போ ஒரு 1 month கழிச்சு வந்தா கூட ஓகே தான், பிரச்சனை இல்லை. ஏன்னா இது 3 months இல்ல மேக்ஸிமம் 4 months தான் நம்ம இது யூஸ் பண்ண முடியும். அப்ப அந்த ஃபர்ஸ்ட் சர்ஜரிக்கு முன்னாடி நம்ம போட வேண்டிய ஒரு அப்ளைஸ் தான் இது. அப்போ எல்லார்கிட்டயுமே என்ன ரிக்வெஸ்ட்னா, இப்போ ரிக்வெஸ்டே தான். ஏன்னா என்கிட்ட வர நிறைய பேஷண்ட்ஸ் வந்து அப்படிதான் இருக்காங்க. ஒரு 3 months கழிச்சு வீட்டுல போய் டிஸ்சார்ஜ் ஆகி வீட்டுக்கு போய் 3 months அப்புறமா தான் இங்க வராங்க நிறைய பேர். அதனால என்னால எதுவுமே செய்ய முடியல. இவ்வளோ பேஷண்ட்ஸ் இருக்காங்க நம்மளுக்கு. ஆனா ஒரு 10 பேஷண்ட்ஸ் இருக்குதுன்னா அதுலயே வந்து ஒரு 3-4 பேஷண்ட்ஸ் மட்டும்தான் இப்போ ஓக்கலாண்டிக் ட்ரீட்மெண்ட்டுக்கு ரெடியா இருக்காங்க. ஏன்னா அவங்க வர டைமிங்கே வந்து இந்த மாதிரி ஒரு 3 months கழிச்சு இல்ல 4 months கழிச்சு வெயிட் ஏறதுக்கு வெயிட் பண்றாங்க, இல்ல ஹெச்பி லெவல் ஏறதுக்கு வெயிட் பண்றாங்க. ஆனா நம்ம சைடு பாத்தீங்கன்னா இந்த மாதிரி ட்ரீட்மெண்ட்டும் நம்மளுக்கு தேவைதான். குழந்தைய பொறுத்த வரைக்கும் அது தேவைதான். அப்புறமா நான் போட்ட பிறகு வாரம் இல்ல 2 weeks once வந்து நம்ம இங்க வந்து மேம் அட்ஜஸ்ட்மெண்ட்காக நம்ம கூப்பிடுவோம் எல்லா பேஷண்ட்ஸையும். இந்த போட்டோஸுமே பாத்தீங்கன்னா உங்களுக்கு தெரியும். இது வந்து ஃபர்ஸ்ட் போட்டோ வந்து நான் போட்ட போட்டோ தான். இங்க இருக்கிறது ஃபர்ஸ்ட் வந்து லிப் டேப்பிங் பண்ணிருக்காங்க குழந்தைக்கு. ஸ்டெரிஸ்டிக்ஸ் தான் நம்ம யூஸ் பண்றோம் அதுக்காக. இப்போ வார்டில் இருக்கிற இல்ல எல்லா சிஸ்டர்ஸ்க்குமே தெரியும்னு நினைக்கிறேன். ஸ்டெரிஸ்டிக்ஸ் நம்ம யூஸ் பண்ணி மேக்சிமம் இந்த உதடு வந்து இந்த ப்ரெஷர் யூஸ் பண்ணி ரொம்ப கிட்ட வர மாதிரி நம்ம டேப்பிங் பண்றாங்க ஃபர்ஸ்ட். அதுக்கப்புறமா தான் நம்ம இந்த மோல்டே வந்து நம்ம வாய் உள்ள போடுறோம். அதோட சேர்த்துதான் இந்த நோஸ்ட்ரில் உள்ள போடுற அது ஒரு அக்ரிலிக் பார்ட் தான். அப்பதான் அந்த நோஸ்ட்ரில் ஷேப்பே வந்து கரெக்டா வந்துடும். செகண்ட் போட்டோ வந்து சர்ஜரிக்கு அப்புறமா இருக்கிற போட்டோ தான். அதாவது நீங்க பாருங்க, ஏதாவது சர்ஜரி பண்ணதுக்கு அப்புறமா குழந்தைக்கு வந்து இந்த மாதிரி ஏதாவது கிளிப் இருக்கிற மாதிரி தெரியல அவங்களுக்கு. அந்த அளவுக்கு நம்மளுக்கு டிஃபரன்ஸ் தெரியும். இப்போ மதியம் வந்து டெமோன்ஸ்ட்ரேஷன்ல வந்து நம்ம இப்ப பண்ணிட்டு இருக்கிற ஒரு பேஷண்ட கொடுத்துருக்கோம். அப்போ உங்களுக்கு தெரியும் எந்த அளவுக்கு அந்த கேப் வந்து கம்மி ஆயிடுச்சுன்னு சொல்லிட்டு. அதாவது நம்ம மேக்சிமம் பிறந்த உடனே வந்து குழந்தைய இங்க அனுப்பணும். அதுதான் மெயினா. அப்பதான் நம்மளுக்கு இந்த ஓர்த்தோ சைட்ல இருந்து என்ன பண்ண முடியுமோ அதை பண்ண முடியும். பிறந்த உடனே இங்க அனுப்புனாங்க அப்படிங்கிற மாதிரி இருந்துச்சுன்னா, இப்ப எப்படி எல்லாம் வீட்டுல வந்து ஃபர்ஸ்ட் ஏதோ அம்மாக்கும் நம்ம போடும்போது பாத்தீங்கன்னா, இப்ப இங்கே நம்ம கிட்டே வர நிறைய அம்மா என்ன பண்ணுவாங்கன்னா, நம்ம முன்னாடியே அழைச்சிட்டு இருப்பாங்க நம்ம போடும்போது. நம்மளுக்கும் கஷ்டமா தான் இருக்கும். ஆனா என்ன, அது போட்டா அதோட ரிசல்ட் என்னன்னு பார்க்கும்போது கண்டிப்பா அவங்க வந்து போடுறதுக்கு ஓகேவா தான் இருப்பாங்க. ஏன்னா நம்மளால இங்க இருந்து போட்டு விட முடியும். அதுக்கப்புறமா அது கண்டினியூ பண்றது, டெய்லி அதை சேஞ்ச் பண்றது எல்லாமே அவங்க தான் பண்ணணும் வீட்டுல இருக்கு. அது கொஞ்சம் கஷ்டமான, அது மெனக்கெட்டு பண்ற ஒரு வேலை தான். ஆனாலுமே அது பண்றதுக்கு அப்புறமா இருக்கிற ரிசல்ட் பார்த்தா எல்லாருமே பண்றாங்க. அது நீங்க வந்த எல்லாருமே அது பண்ணிட்டு இருக்காங்க. அதோட இம்ப்ரெஷன் டெக்னிக் தான் அடுத்து நான் சொல்ல போறேன். இப்போ நம்ம அந்த பிளேட் தயாரிக்கிறதே வந்து அக்ரிலிக் மெட்டீரியல் யூஸ் பண்ணிடலாம். நம்ம அந்த பிளேட் தயாரிக்கிறது, அப்புறம் ஸ்டெயின்லெஸ் ஸ்டீல் வயர் தான் அதுக்கு யூஸ் பண்றது. அதுக்கு வந்து 2 அளவு எடுக்கும். இல்ல குழந்தை வந்து ரொம்ப வந்து கோஆப்ரேட் பண்ணல அப்படிங்கிற மாதிரி இருந்துச்சுன்னா 3 அளவு வரைக்கும் நம்ம எடுக்கலாம். 2 அளவு கண்டிப்பா நம்ம எடுத்துதான் ஆகணும். ஏன்னா ஒவ்வொரு குழந்தையோட அளவு வித்தியாசமா தான் இருக்கும். அதனால ஃபர்ஸ்ட் ஒரு குழந்தையோட அளவு எடுத்த பிறகு அந்த பிளேட் தான் நம்ம செகண்டரி அளவு மறுபடியும் எடுக்க போறோம். இப்ப இங்க பாத்தீங்கன்னா நம்ம ஹெவி பாடி சிலிகான் இம்ப்ரெஷன் மெட்டீரியல் தான் நம்ம இங்க யூஸ் பண்ணுவாங்க. ஏன்னா அது வந்து ரொம்ப சாஃப்ட் மெட்டீரியல். குழந்தையோட இப்ப நம்மளுக்கே ஒரு டென்டல் இம்ப்ரெஷன் எடுக்கும் போது எந்த அளவுக்கு நமக்கு இரிட்டேஷன் இருக்கும்னு நம்மளுக்கே தெரியும். டென்டல் கிளிப்ஸ் எல்லாம் நிறைய பேர் போட்டிருப்பாங்க. அப்போ குழந்தைக்கு வந்து ஆல்ரெடி கிளிப் பேலன்ஸ் இருக்கிற குழந்தைக்கு வந்து நம்ம அதை எடுக்கும் போது ரொம்ப கஷ்டமா தான் இருக்கும். குழந்தை வந்து புதுசோட அழுதுட்டே இருந்தாதான் நம்மளால அதை பண்ண முடியும். அனஸ்தேஷியா போட்டோ இல்ல வேற ஏதாவது பண்ணியோ நம்ம பண்ண முடியாது. ஒரு குழந்தைக்கு இம்ப்ரெஷன் எடுக்கிறதுக்கு ஒரு மணி நேரம் முன்னாடியாவது ஃபீட் பண்ணி முடிச்சிருக்கணும். அதுக்கப்புறமா 1 hour வந்து நம்ம ஃபீட் பண்ணவே கூடாது. அப்பதான் நம்ம கரெக்ட் அளவு எடுக்க முடியும். இந்த போட்டோஸ்ல உங்களுக்கு தெரியும் எப்படி குழந்தைக்கு அளவு எடுக்கிறோம் சொல்லிட்டு.
ஒரு சர்ஜனோட பிரசன்ஸ்ல வந்து குழந்தைய வந்து நல்லா அழ வச்சுதான் நம்ம அந்த அளவே எடுக்க முடியும். அப்பதான் அந்த ஃபுல் ஓரல் ஸ்ட்ரக்சர்ஸே வந்து நம்ம இம்ப்ரெஷன்ல பதியணும்னா அந்த மாதிரி ஃபுல்லா அழுதுட்டு தான் நம்ம எடுக்கணும். அப்புறம் வந்து குழந்தைய வந்து ஃபுல்லா உங்களுக்கே தெரியும், ஃபுல்லா துணி இல்ல ஏதாவது நம்ம கிட்ட இருக்கிறத வந்து கோடி ஃபுல்லா சுத்தி வச்சு குழந்தைய நல்லா புடிச்சு வச்சு அப்படிதான் நம்ம அளவே எடுக்கணும். இது வந்து அளவு எடுத்தது. இது வந்து மெட்டீரியல், சிலிகான் மெட்டீரியல். இது வந்து அளவு எடுத்த பிறகு இருக்கிற இம்ப்ரெஷன் தான் இது. இது வந்து யூனிலேட்ரல் கிளப் லிப் அண்ட் பேலட் தான். இது வந்து அந்த இம்ப்ரெஷன் எடுத்து அதுல வந்து நம்ம பிளாஸ்டோ பாரிஸ் இல்ல டென்டல் ஸ்டோன், டை ஸ்டோன் ஏதாவது போர் பண்ண பிறகு இருக்கிற இப்படிதான் இருக்கும் குழந்தையோட வாயுள்ள அந்த பேலட் மவுத்தோட அது வந்து எப்படி இருக்குமோ அதுதான் போசிட்டிவ் ரெப்ளிகா தான் இது. இதுலதான் நம்ம வந்து ஒவ்வொரு பிளேட்டும் செய்ய போறோம். இது வந்து ஃபர்ஸ்ட் இம்ப்ரெஷன் எடுத்த பிறகு இந்த மாதிரி ஒரு காஸ்ட் போர் பண்ணிட்டு அதுலதான் நம்ம மறுபடியும் பிளேட் பண்ண போறோம். அந்த பிளேட் வச்சு ரெண்டாவது இம்ப்ரெஷன் நம்ம மறுபடியும் எடுக்கணும். இங்க பாத்தீங்கன்னா ஃபர்ஸ்ட் காமிச்சு போட்டோல வந்து பிளாஸ்டோ பாரிஸ் வச்சு நம்ம எடுத்த ஒரு காஸ்ட். இது வந்து டெண்டல் ஸ்டோன் அப்படின்னு சொல்லுவாங்க, கிரீன் ஸ்டோன் அப்படின்னு சொல்லலாம். இது வச்சுதான் நம்ம வந்து அந்த காஸ்ட் போர் பண்ணுவாங்க. இந்த காஸ்ட்ல வந்து எங்க இன்சர்ட் பண்றதுக்கு கஷ்டமா இருக்கிற இடங்கள் வந்து நம்ம ப்ளாக் அவுட் பண்ணிட்டு அதில் தான் இங்க பிளேஸ் பண்ணுவாங்க. இது வந்து யூனிலேட்ரல் கிளப் லிப் அண்ட் பேலட் இருக்கிற குழந்தைக்கு போடுறதுக்கு தான் செகண்ட் பிக்சர்ல போட்டிருக்குது. செல்ஃப் பியூர் மெட்டீரியல்ல நம்ம நார்மல் டெம்பரேச்சர்லயே செட் ஆகிற மெட்டீரியல் தான் அக்ரிலிக் கோல்ட் பியூர் மெட்டீரியல் அப்படிங்கிறது. அது வச்சுதான் நம்ம இது பண்ண போறோம். அந்த நோஸ்டில்ஸ் உள்ள போடுறதா அந்த ஸ்டெயின்லெஸ் ஸ்டீல் வயர் யூஸ் பண்ணிட்டு பெண்ட் பண்ணி நோஸ்டில் உள்ள போடுற மாதிரி. அது அவ்வளவு பெருசா போட்டா மட்டும்தான் இன்னொரு நோஸ்டில் எப்படி இருக்குமோ அந்த மாதிரி அந்த ஷேப் வந்துடும். அதனாலதான் அவ்வளவு பெருசா அதை வச்சிருக்காங்க. இது எல்லாத்தையும் ஒரேடியா நம்ம குழந்தையோட வாயில போட முடியாது. அதனால ஃபர்ஸ்ட் வீக்ல வந்து நார்மல் கிளிப் மட்டும் நம்ம போடுவோம். இந்த நாஸ்டில்ஸ்ல போடுற அந்த எக்ஸ்டென்ஷன் இல்லாம அக்ரிலிக் பிளேட் மட்டும் அதுக்குள்ள போட்டுட்டு 1 வீக் வந்து குழந்தைய வந்து நம்ம ஒப்சர்வ் பண்ணுவோம். எப்படி இருக்கு குழந்தை, நல்லா ஃபீடிங் எடுத்துக்கிறாங்களா, அப்புறம் ரொம்ப அழுதுட்டு இருக்கானா, ஏதாவது டிஸ்டர்பன்ஸ் இருக்கா. ஏன்னா இதை பொறுத்த வரைக்கும் இது ஒரு அக்ரிலிக் பிளேட் தான். அதனால குழந்தைக்கு எந்த அளவுக்கு இச்சிங் இருக்குமோ இல்ல வேற ஏதாவது பிரச்சனை இருக்குமோ நம்மளுக்கு தெரியாது. அதனால 1 வீக் வந்து நல்லா ஒப்சர்வ் பண்ண பிறகுதான் நம்ம வந்து நெக்ஸ்ட் நோஸ்டிலுக்கு வந்து எக்ஸ்டென்ஷன் கொடுப்போம். நம்ம இந்த அப்ளையன்ஸ் வந்து இன்சர்ட் பண்றதுக்கு முன்னாடி நம்ம இந்த ரஃப் ஏரியாஸ் எங்கெங்க இருக்கு அப்படின்னு பார்த்துட்டு அதெல்லாம் நல்லா ட்ரிம் பண்ணி ஸ்மூத்தன் பண்ணி தான் நம்ம இது டெலிவர் பண்ணணும் குழந்தைக்கு. ப்ராப்பரா ஃபிட்டிங்கா இருக்கா, ரிட்டர்ஷன் இருக்கா. குழந்தைய பொறுத்த வரைக்கும் பணம் கிடையாது. இருக்குங்கிற ஒரு இது இல்லாததுனால நம்ம வந்து எக்ஸ்டர்னல் டைப்பிங் மூலியமா மட்டும்தான் நம்மளுக்கு அது வந்து உள்ள போட முடியும். அதுதான் இந்த ஸ்டடி ஸ்ட்ரிப்ஸ். அப்புறம் இங்க வந்து மைக்ரோபோர் யூஸ் பண்றாங்க. இப்போ நம்ம கிட்ட வர பேஷண்ட்டுக்கு ஃபர்ஸ்ட் டைம் இந்த நேம் போட போறோம்னா போட்ட பிறகு நம்ம 1 hour இங்க வெயிட் பண்ண வைக்கணும். வெயிட் பண்ண வச்சு குழந்தை எப்படி அழுதுட்டு இருக்கா இல்ல ஃபீடிங் எல்லாம் நல்லா எடுத்துக்கிறானான்னு பார்த்த பிறகு அந்த 1 hour முடிச்சுட்டு தான் நம்ம இங்க இருந்து போவிடுவோம். அதுக்கப்புறமா ஒரு 24 hours கழிச்சு, அதாவது நெக்ஸ்ட் டே வந்து மறுபடியும் வந்து செக்அப்புக்கு வர சொல்லுவாங்க. செக்அப் முடிச்ச பிறகு ஓகேவாயிடுச்சுன்னா திரும்ப முன்னாடி சொன்ன மாதிரி 1 வீக் கழிச்சு வந்து நேசல் எக்ஸ்டென்ஷன் போடுற மாதிரி தான் இருக்கும் குழந்தைக்கு. அந்த ஸ்டெரி ஸ்ட்ரிப்ஸ் வந்து நம்ம டெய்லியும் வந்து சேஞ்ச் பண்ற மாதிரி தான் இருக்கும். ஏன்னா குழந்தை வந்து பால் குடிக்கும் போது அந்த பால் பட்டி அந்த ஸ்டெரி ஸ்ட்ரிப்ஸ் வந்து எடுத்து வந்துடும். அப்ப அதுல கம் இருக்காதுங்கிறதுனால நம்ம ஸ்டெரி ஸ்ட்ரிப்ஸ் வந்து டெய்லியும் வந்து சேஞ்ச் பண்ணிட்டே இருக்கும். இது எல்லாமே பேரண்ட்ஸ் வந்து வீட்லயே செய்ய வேண்டிய விஷயம். இப்போ இங்க வர ஒரு ஃபேமிலி இருந்து வரவங்க நிறைய பேர் நாங்களே வீட்டுல செய்வோம் அப்படின்னு சொல்லிட்டு போவாங்க. இப்ப மத்தவங்க நிறைய பேர் வந்து நாங்க இங்க வருவோம் நீங்களே ஊத்தி விடுவீங்களா அப்படின்னு கேட்கிறவங்களும் இருக்காங்க. ஆனா இப்ப நம்மளை பொறுத்த வரைக்கும் அது வந்து டெய்லி ஒட்டி விடுறது பிரச்சனை கிடையாது. ஒரு 2 hours ஒன்ஸ் நம்ம ஃபீட் பண்ணும்போது திரும்ப அது கழட்டி வர்றதுக்கு வாய்ப்பு அதிகம். அப்ப அவங்களே ஒட்டிதான் ஆகணும். அதனால எல்லா பேஷண்ட்ஸுக்குமே நம்ம இங்க இருந்து அது எப்படி போடுறது, எப்படி கழட்டுறது, எப்படி கிளீன் பண்றது எல்லாமே நம்ம சொல்லி கொடுத்துட்டு தான் அனுப்புவோம். இது வந்து பாத்தீங்கன்னா பைலேட்ரல் கிளப் அண்ட் பேரட் தான். நீங்க உள்ள பாத்தீங்கன்னாலே தெரியும் உள்ளர எந்த அளவுக்கு அது கரண்ட் ஃபிட்டிங்கா இருக்கு. அந்த கிரீன் கலர் காமிக்கிறத வந்து ஓரல் எலாஸ்டிக்ஸ் சொல்லுவாங்க. அது வந்து நார்மல் எலாஸ்டிக்ஸ் விட கொஞ்சம் ஸ்ட்ராங்கா கொஞ்சம் சின்னதா இருக்கும். அது வச்சுதான் நம்ம இந்த ஸ்ட்ரிப்ஸ் வந்து ஸ்டெரி ஸ்ட்ரிப்ஸ் இல்ல வேற ஏதாவது ஸ்ட்ரிப்ஸ் நம்ம ஒட்டுறத வந்து ப்ராப்பரா அலைன் பண்ணி ஒட்டுறத வந்து அந்த ரப்பர் பேண்ட் வச்சுதான். அந்த ரப்பர் பேண்ட் வந்து எதுல அட்டாச் பண்றதுன்னு பாத்தீங்கன்னா அது ஒரு ஸ்க்ரூ இருக்கும். ஸ்க்ரூனா அக்ரிலிக்லயே பண்ற ஸ்க்ரூ தான், நம்மளே கையாளுற ஸ்க்ரூ தான். அதை வந்து மதியம் வந்து டெமோன்ஸ்ட்ரேஷன்ல நான் காமிக்கிறேன். இது எப்பத்துல இருந்து எப்ப வரைக்கும் போடணும்னு பாத்தீங்கன்னா சொன்ன மாதிரி பிறந்த உடனே அதுல இருந்து ஒரு 3 months வரைக்கும் யூனிலேட்ரல் அந்த மாதிரி கிளப் பேஷண்ட்க்கு ஒரு 3 months வரைக்கும் நம்ம போடலாம். அதாவது ஃபர்ஸ்ட் லிப் சர்ஜரி பண்ற வரைக்கும் நம்ம பண்ணலாம். அதுவே அது பைலேட்ரல் இருந்தா ஒரு 6 months வரைக்கும், அதுவே ஃபர்ஸ்ட் சர்ஜரி முடிக்கிற வரைக்கும் தான் நம்ம போட முடியும். இது போட்ட பிறகு நம்ம வீக்லி செக்அப் அப்படி ஏதாவது இரிட்டேஷன் இருக்கா, இன்ஃபெக்ஷன் கரெக்டா இருக்கா, இதெல்லாம் வீக்லி செக் பண்ணிட்டே இருக்கும். இதோட காம்ப்ளிகேஷன் அப்படின்னு பார்க்கும்போது அக்ரிலிக் மெட்டீரியல் வந்து எல்லா ஸ்கின்னுக்குமே வந்து ஒத்துக்காது. அதனால வந்து இரிட்டேஷன் பிரச்சனை இருக்கிறதுக்கு வாய்ப்பு அதிகம். இப்ப அதெல்லாம் வரும்போது குழந்தை எப்படி பிஹேவ் பண்ணணும் அது எப்படின்றது இப்போ ஒரு அம்மாக்கே தெரியும் குழந்தை ரொம்ப அழுதுட்டு இருக்கு, இல்ல வேற ஏதாவது க்ளூஸ் கொடுத்துட்டே இருக்கு, இந்த மாதிரி இரிட்டேஷன் இருக்குங்கிற மாதிரி இருக்கும்போது நம்ம கழட்டி வச்சிடணும் அது. ஏன்னா இது அக்ரிலிக், வேற எதுல நம்ம செய்ய முடியாது இது. அதனால அந்த மாதிரி பிரச்சனைனா நம்ம உடனே அது கழட்டி வச்சிடணும். அதாவது இப்ப என்ன சொல்லணும்னா எனக்கு இருக்கிற ஒரே ஒரு 19 தான். அதிலிருந்து நம்ம கிட்ட ஒரு 50 பேஷண்ட்ஸ் தான் வந்திருக்கு. அதுக்கு மேல வர மாட்டேங்குது. ஏன் ரீசன் கேட்டீங்கன்னா பிறந்த உடனே இந்த மாதிரி அவங்களுக்கும் தெரியல, அந்த குழந்தைய பார்த்துட்டு இருக்கிற டாக்டர்ஸுமே பீடியாட்ரிஷியனுமே வந்து எதுவும் சொல்லல, சிஸ்டர்ஸுமே எதுவும் சொல்லல, அங்க இருக்கிற ஹெல்த் கேர் ஒர்க்கர்ஸுமே எதுவும் சொல்லல. இந்த மாதிரி 3 months பிறந்த உடனே இங்க வரணும், இந்த மாதிரி ட்ரீட்மெண்ட் பண்ணணும்ன்றது. அதனால வந்து நிறைய பேஷண்ட் வந்து இங்க வராம இருக்கு. அதனால என்னன்னா இனிமேயாவது நீங்க எல்லாருமே தெரிஞ்சுக்கணும் இந்த மாதிரி ஒரு ட்ரீட்மெண்ட் இருக்கு. எத்தனை பேருக்கு தெரியும் இந்த மாதிரி ஒரு ஸ்னாப் போடணும், இந்த மாதிரி குழந்தைங்க யாருக்காவது தெரியாதுல்ல, அதான் சொல்றேன். அதனால என்னன்னா நீங்க இனிமேலாவது அந்த மாதிரி குழந்தைகள் இருக்கும் போது இப்ப இங்க இல்ல வெளியே கூட உங்களுக்கு தெரிஞ்சவங்க இருக்கும் போது கண்டிப்பா நீங்க இந்த மாதிரி லோக்கல் டிஸ்ட்ரிக்ட் லோக்கல் டெக்னீஷியன் நீங்க பார்த்துதான் ஆகணும் அப்படிங்கறத நீங்க சொல்லணும். அப்பதான் எங்க சைட்லயுமே என்ன பண்ண முடியும், அந்த குழந்தைய வந்து எவ்வளவு அழகா நம்ம ஒரு வயசுக்கு அப்புறமா சர்ஜரி எல்லாம் முடிச்ச பிறகு ஒரு அளவுக்கு நம்ம அழகா வந்து எப்படி பண்ணலாங்கிறது நம்ம பார்க்கணும். அவ்வளவுதான், எல்லாருக்கும் புரிஞ்சிருக்கும்னு நினைக்கிறேன்.
Thank you, ma'am. Now I call upon Mrs. S. Vijayalakshmi, nursing officer, to address malnutrition in children with cleft lip and palate, vegetables and interpreting.
Good morning, everyone. Welcome to my session. Can we start the session?
Yes.
Are you all active? Okay, we shall start the session. I am Vijayalakshmi, nursing officer from nephrology ward. Like since morning, we are discussing so many topics under this mentorship program. Now also we are going to discuss another important topic. Like before going into the topic, just have a look at this picture in the slide. Just see, it is a springboard for our discussion. Please maintain silence. So what do you observe from this picture? Yeah, it is a child affected with cleft and also malnourished, isn't it? So this malnutrition is a significant concern in the cleft when a child affected with cleft because it will have feeding difficulties and gradually it will lead to nutritional deficiency. So we need to address this malnutrition. So our topic is on addressing malnutrition in cleft, in children with cleft lip and cleft palate. And another topic is measuring and interpreting growth. It is not a separate topic, like together we will discuss. So we shall move on. So do you think addressing malnutrition is important? Yes? Yes, there is no binary answer for this. Like addressing malnutrition is very important. One and only answer, it is yes. Because malnutrition will delay the treatment. And so it is essential that we address the malnutrition. So it is the most under-recognized danger and a life-threatening impact of malnutrition. So it is under-recognized danger and it is pernicious. It is not pernicious anemia, it is pernicious. Okay, so it is very harmful. Like when malnutrition is not detected in the child affected with cleft, it may be harmful and it delays the treatment also. So it is pernicious and the children will have challenges in eating, speaking, and then there is a risk of breathing and hearing issues. So we need to address this malnutrition. So as per a statistical report, like Asia and South African countries are mostly affected with this malnutrition. The children affected with cleft. In Africa and South Asia, as many as 1 in 3 children are underweight. They are malnourished, and children under the age of 5 with cleft are nearly 2 times more likely to be malnourished than the children without them. So 2 times they are affected than the normal children. And as of 2020, nearly 2 lakh children with cleft are malnourished. Most of them living in low and middle income countries. Okay, this figure has not changed even after 3 or 4 years of census activity. So the figure remains the same. There's 2 lakh children are affected with cleft. And globally, around 5 million people are living with untreated cleft. So in that bar diagram, we can see Asia and the South Africa countries are mostly affected with this cleft. How cleft affect the nutritional status? So actually, we feel it is a cosmetic, like often it is mistaken as a cosmetic thing, but it's not so. Like even though they don't have swallowing problems, but this cleft, that is the children affected with cleft, they have a problem in creating the pressure, positive pressure and negative pressure. So in that case, they are not able to suck the milk, okay, and then swallow it. So there is a problem with that. So we need to correct that. So nasal regurgitations and choking, increased aspirations are all the problem. So they will not get enough milk. So they keep on that is prolonged sucking that leads to fatigue. We'll see the pathophysiology of this. The presence of a cleft reduces an infant's ability to create suction. Then difficult or impossible for them to get milk and even swallow. This was self-explanatory. And then that leads to excessive air intake. They will not get adequate milk, but excessive air intake is there, gagging and increased risk of respiration, infection from the presence of milk in their lungs and airways. Exhausted by their struggle to feed and feeling full due to the large amount of air in their stomach. They won't take milk, but instead of that, they take air. No, so they have the feeling of fullness in their stomach, but they will not get adequate nutrition or calories. Babies with cleft often stop nursing before they have adequate calories and nutrients. Are you clear with this methodology? Babies and children cleft become so gradually they become underweight and risk of growth failure and death. Yes. So we have challenges when we talk about this malnutrition. We face some real challenges. This first one is lack of information about how to feed babies with cleft. No, first we should have adequate knowledge when imparting education to the mother or assistant. So, lack of information and lack of scarcity of health workers. Health workers must be trained enough to teach the mother. Next is anemic patients. So, already this patients, that is the child affected with cleft, may be malnourished. In that case, anemia will also be there. The parents may not be aware the child must be given iron supplements. So, they are not aware of it. In that case, anemia will worsen further. Lack of clean water, as in developing countries, as it leads to diarrhea and parasitic which weaken the patients. So these are the challenges. So what are the methods to reduce malnutrition in children with cleft? There is some protocol it is formulated to reduce the malnutrition in children. So first is devising neonatal care related guidelines. So newborn care is universal. In that palate examination can be included. Okay. Next is maintaining national and regional population-based registry for cleft children. This registry can be used for research purposes also. And then for prevention modalities. And then advising national feeding and nutrition guidelines for the vulnerable children. That is for the vulnerable group. That is children with the deformities, is cleft, child affected with cleft. Next is malnutrition screening and food assistance program. In what way? Like the feeding can be enhanced. So some feeding practices and feeding techniques can be formulated that can be made practically possible. And then educating the community to combat the stigmatization. So this morning we are discussing about stigma. You know the parents will be having stigma. So how to combat the stigmatization? So first they have to come out. That is the mother, the parents must be come out of the stigma. First of all, they have to accept the baby. Then only they will take whatever we tell. They have to combat, they have to educate the community to combat the stigmatization. Next is counseling. The knowledge must be, knowledge of the mother must be built upon the existing knowledge. Okay, what they know. And then next we have to tell them whatever is required. The counseling is very essential and knowledge must be given and guidance and supportive care is needed. What is our role? So we have seen this protocol and all. So what is our role? What actively we are going to do? We should have knowledge about the cup feeding, spoon feeding. Those things sister have discussed already. So I'm not going to that in detail. So identify the signs of developmental readiness. First, the child, we should find out whether the child is really ready. Developmentally, it is ready to accept the solid foods. Next, appropriate food textures. Food textures we have seen, sitter, crawler, walker. So based on that, the feed can be given and understand that unprepared cleft or palate does not exclude the child from being offered spoon feeding. Then identify the benefits of providing spoon feeding to children with unprepared cleft. So we have addressed the malnutrition. Another part we are going is measuring and interpretation of growth. This is very essential. So we must be whatever we are going to discuss now already you'll be knowing about it. So you can also contribute your points. So what are we are going to learn from this? This growth assessment. Next is weighing and measuring techniques. These techniques will be demonstrated in the afternoon session. And then errors in those measurements. Common errors what we make when we measure the child, when we take weight or height, whatever it is, like this anthropometric measurements, what are the common errors we do make? Then WHO growth chart. No, it is a standard protocol. We have different growth charts, but what we follow here is the WHO growth charts. Then how to interpret growth points and patterns. How we are going to plot it and how we are going to interpret. Then concerns with growth, next practice session we'll see in the afternoon. So these are things we are going to see now. Same. So growth assessment, what to assess, what we are going to assess in the growth assessment part. So, committee measure is weight, height, no? Is mid upper arm circumference, head circumference, arm circumference. So those things we are going to check under this. So we are going to assess this. So after assessing this, when we assess this only, will be knowing whether child is nutritionally this is well nourished or malnourished. That is more important. This is essential, even essential for the normal child. That is for the child affected with the left is very, very important. Next, why to assess? Why do we need to assess? So is there any significance? Why do we need to assess? Yes, to find out any growth problem. Yeah, is there any risk factors? And then to respond to the intervention. So there is some issue with the weight. So we are addressing that problem to the healthcare worker and some interventions are given. And then again we are taking that's anthropometry we are taking. So next we will see whether the interventions are really helpful or not. So for that also we need to assess that. Then particularly why we are focusing on the under 5 children, under 5 group. Yeah, in long term it's going to determine the children long term health and well-being to identify and address growth problems early in their life will give children a chance to thrive. But the first 5 years are very important. Okay, even the growth chart is also based on that. WHO growth chart. Next, what are the steps in growth assessment? So we have certain steps. We have 5 steps. So we'll see one by one. Measure the weight of the child. First, we are measuring the weight of the child. That is the first step. And we have recorded it. And then compare measurements to standards. What is the standard? What we are following is the WHO growth chart. So we are comparing it. What is the actual child's anthropometry and comparing it to the standard protocol. That is expected outcome. Not outcome, expected result. Okay. And then design a care plan. So discussing with the healthcare worker, we design a care plan. If the child is underweight, we'll make interventions for gaining weight. Okay. So we'll concentrate on it. There is a feeding technique, everything. So we design a care plan. Then comes in the caregiver. Caregiver is the mother. Only mother, no, we will tell them like how the child has to be fed and what are the things we need to concentrate on. And then for the regular checkup, so everything will be telling. So we are counseling the mother. It has to be built on the existing knowledge what the mother has. The follow-up visits are very essential where the child financial status is really improving or not. So are you clear with it? Steps in growth assessment, measure the weight of the child, compare measurements to standard, then design a care plan, counsel the caregiver, then follow visit. Yes? For the class monotonous? Yes, boring? Next, we'll see the growth indicators. Okay? What are the growth indicators? What is on this slide? You all know this. So you can answer. Weight, length and height. Length in small babies, height will measure older babies, and then mid upper arm circumference, and then head circumference. These demonstration will be seen in the afternoon session. Okay. Why to take accurate measurement? We are checking all the anthropometry. Then why do we need to take accurate measurement? If inaccurate measurements are taken, again the treatment is going to be delayed. The weight, the child has not gained adequate weight. Do we take the child for surgery? No, no. So we need to take the accurate measurement leads to accurate interpretation of the growth. And then assess the nutritional status and the severity of malnutrition in the children. How far the child is malnourished. So whether the child is healthy or not. And then assess the prevalence and severity of malnutrition in a group of children. Okay. This chart helps us to identify not an individual child but also a group of children. And then intervene appropriately where needed. So we need to take interventions, formulate the care plan, then we need to intervene. Then track the impact of intervention to inform the clinical decision. Clinical decision, what they mean is about the surgery and the treatment process. So we need to take accurate measurement for these purposes. What happens if accurate measurements are not taken? We have given the inaccurate details. What happens? So incorrectly diagnosing the situation. Hope not. It is self-explanatory. Incorrectly diagnosing the situation, fail to intervene appropriately, children's nutritional status deteriorates. No, we are not giving enough concentration on weight, as weight gain, what happened? We may not concentrate on the nutritional aspect. So we may, that is the nutrition status of child may be ignored. So the nutrition status again deteriorates. Clinical team relies on weight to determine eligibility for cleft repair. That is the most important point. And unable to monitor progress post repair. Post repair also we need to monitor the progress of the child. The treatment care with the adequate management and provision of cleft care. What are the common errors we do make in measurement techniques? We all know how to take weight, height, and everything. Yes, but we do make some errors. No. So what are the common errors? The first is equipment setup. This also will be explained in the demonstration session. Okay. So equipment setup. How we are setting up the equipment. Appropriate equipment for the appropriate age child. For infant, can we use the weighing scale? No. What I mean to say is that only equipment setup. Infantometer must be used. So that is the equipment setup. And preparation of the child for measurement. Next is measuring techniques. The technique what we use. It should be according to the protocol. Then reading of the measurement. Reading of the measurement is maybe our errors. So we have to concentrate on it. And then the recording. We should record the correct measurement. These are the common errors. This will be explained. On equipment setup, preparation of child for measurement, measuring technique, reading of the measurement and recording of the measurement. For this is also under error only. For any type of measurement, if the child is restless or moving, we cannot measure the accurate weight or height. And then the reading or recording of measurement is inaccurate. And measuring does not measure does not read measurement at eye level. Whenever we take the measurement, we should take at the eye level. Okay, that is most important. And then length height assessment errors. The wrong method or equipment, as I explained earlier. And then the child has shoes, headgear, or hair ornaments. And then child's knees are bent. The child legs must be straight whenever we take the height. So the knees must not be bent. The child's feet are not flat. Whenever we measure the height, it must be flat. It should stand like both the feet must be flat. The child's head is not straight. The board is not firm against the feet or the head. One foot is used to measure length instead of both foot. Weight assessment error. The child is wearing heavy clothing. The infant has a wet diaper. The infant is weighed after feeding. The scale is not calibrated. So the scale must be calibrated before taking weight. The scale is not zeroed before weighing. The scale is set to the wrong unit. Mid upper arm circumference adjustment errors. The midpoint, the wrong midpoint is incorrectly marked. The tape is too loose or too tight. The tape is not placed in the levels. We shall see in the afternoon session. Head circumference assessment error. So the tape is too loose. Whenever we take the head circumference, when the tape is too loose, the ideal weight cannot be ideal measurement cannot be done. The tape is too high or wraps over the ears. Let's make some height values. Let's find out what's wrong with this picture. To find out the error. Maybe some taken away. Is there any right in this right?
Only one leg is there.
Yes. So these were the common errors we made. No. Right, made side holding the huh? Weights for the child is not appropriate. Next, in this picture,
Over here.
over there, overlapping. Nice. Tape straps over the ears, tape too loose. See, the tape does not go over the femoris, it does not cover the occiput on the back of the head. So like these errors we make. So we have to be careful whenever we take these measurements. In this picture, one step is pressing against the wall. Yes. Hands. Hands. Yes. Examiner hand is over the baby. No, not Maybe measure hand on him. Touching the wall. Yeah, not it's supposed to be because they on the that is tiny down of dent. No, they is too loose. Incorrect position of the tail. It is very low. It is not in the middle. Yes. Next, we will see the growth chart. The WHO growth chart. We'll see. Okay. So WHO growth chart components. So what are the components in WHO growth chart? So you must be knowing these. First is like let's say let's know gender. We have a separate chart for each gender. Okay, male, baby, and female. For male, it is blue chart, and for female, it is pink one. So we have to select the appropriate chart whenever we do the markings. Right? For gender. Next is age. We have we have different growth charts. Okay, from birth to 6 months, birth to 5 years. Okay, so we have to select the age appropriate charts. Next is x-axis. X-axis is a horizontal line. Yes. So there we mark the age, and then y-axis is the vertical line. There we mark the indicator, the weight or height, whatever it is. And then Z score. You must be knowing about Z score. Yes. Start we can take it as an example. First, we see the x-axis. It is a chart for girl, no females, female child. So it's a pink chart. Now we have an x-axis. Age is marked from birth to 5 years start. Okay. So we have we can mark the measurements in SD or percentage, but let us not be confusing. We can use the SD chart. So this is a standard deviation chart. I tell about it. So in x-axis we have age is marked birth to 5 years. Okay. Usually since 3 months we use weeks. Okay. After that month, and then after that years. Then 5 years. Fine. So from birth to 5 years, the month is also marked in the x-axis. And then in the y-axis, the weight is marked. Then we'll see the Z score. Like in the middle, the green line is there. It is marked 0. No, it is the 50th percentile actually. In SD, I am telling it is 0. It is a median line. Average expected outcome. Okay. And then below that, usually it is marked as 0, -2, -3, and above 0, 2, 3. Okay. So we have to after checking the. I will teach this in a demonstration session. Like we can plot it and see. Okay. So these are the various charts. I will explain you that. See this Z score. This is a median line I told, and then these are all Z scores. Okay, or reference line you will tell. So what are the standard growth charts? We have many charts, but I have listed few. Weight in relation to age. What is weight for age? We have charts separately for boys and girls. For all the cadre. Then weight in relation to age. Next is length or height. Length height for age. Next is weight for length height. Then head circumference for age. Arm circumference for age. So we can see weight and length. So it will not be confusing. So these are all the various charts. So if the child's, so let us see one example. If the child's or baby's weight is going to be, sorry, baby's weight is going to be 9 kg, 9 kg in 1 year. Where we will mark it? Here, no? Here we will mark it 9 kg. So it is, we are marking it along the median line. So it is normal. So when it falls between 2 and -2, it is considered nourished, well nourished baby. It is growing at a healthy pace. Okay. So when the baby is marking, the plotting is done between 3 and 2 or -2 and 3, it is borderline malnutrition. Okay, borderline. Understood? Then below -3, it is severely malnourished. So these things we need to know. Like we need to mark at each visit, whenever the baby visits, we need to make the marking. Then only a pattern is made. Okay, then only a pattern is made. All the plots are connected with the adjacent marking. Then a pattern is made. Okay, then only we can observe the trend how the baby is growing. Your doubts will be clear. I think these lines are called as centile lines or SD curves. We have series of curves. These are all curved lines. Actually, these measurements are converted into statistical representation. That is, the measurements are converted into statistical representation for interpreting it easily. It can be made for the individual child or for the whole population. Then we can observe the trend whether they are growing at a normal pace or not. You can get the answer. The WHO growth chart should be used to monitor the growth of infants regardless of the method of feeding. True or false? True? False? True? Then false. Why it's false? So regardless of the method of feeding, then 6 months we'll give exclusive breastfeeding. After that, we'll give complementary feeds. Then also we mark the chart, isn't it? We use the same chart. Then we observe the trend. So regardless of the method of feeding, we do use the WHO growth charts. So it's true. Next, different growth charts should be used for children with cleft palate. No. Okay. There is no different chart. All girls have the same growth charts because they grow the same way. Yes. The median growth line is followed by the majority of children who are well nourished. Yes. True or false? True. False. Why false? Why true? Yes, majority of the children who are well nourished, who are getting nutritious feed, who are in the normal weight gain and everything, they follow the median growth line. I told you no, it's an average taken as average. So median growth line. The median growth line is followed by majority of children who are well nourished. So it's true. The lines of growth charts for Z4 help us to identify growth concern. Yes? Whether the child is well nourished or moderately or borderline or undernourished. So we are able to find out. So it's true. So here I have plotted this. I have explained this. This age is taken in the x-axis. No, weight in the y-axis. So when we give the marking, like that is, we have to just first we'll see the x-axis. Okay, locate the child's age or length, age or length and weight, whatever chart we take on the x-axis. Extend the vertical line from that point. It is for the explanatory purpose only. I put this line, and then locate the child's measurement on the y-axis. So extend that horizontal line. Both extend both the vertical line and the horizontal line, and then mark a dot in the place where it intersects, where both the x-axis and y-axis line intersect. Then we have to plot it. That point is called plotting. Okay, growth point. That is called as growth point. When a single point is there, it's a growth point. And then for a repeat, it should be repeated for the follow visits. With each visit, it should be repeated. Okay, then only a pattern or trend is observed. This is growth point. When only one marking is there, it is a growth point. When a series of marking is there, it is a growth pattern.
when we do a series of assessment for the same child, we have a series of growth point or growth pattern. Then multiple measurements will provide the adequate detail rather than taking a single measurement. With single measurement, we cannot interpret the result. No. How to interpret growth points? Compare plotted points with the Z-score lines and determine the indicator growth problem. I mean, the growth point between, this I told you, between +2 and -2 Z-score is considered to be in the normal range. Then +2, the growth point above the +2 and below the -2 Z-score indicates the possible growth concern. Maybe the borderline nutritional deficiency. And then growth point between on the Z-score is considered to be less severe category. That is above that is below the -3, it is very severely malnourished. They interpret the growth pattern of the child. Here we can see it is a normal, within the normal Z-score range. It is below +2 and that is within +2 and -2. It is along the model is along the median, so there is no concern. The next one is tracking below the median. You can see below the median. Next tracking above the median. There I have plotted only one growth point. Tracking above the median. So these are all other. That is the next two charts are of concern. We have to rule out the risk factors in this. This you can interpret this chart. What do you observe from this? First, for whom do we use this chart? For boys. Next, it is for the length, appropriate length for age. It is for the length for age. Okay. So x-axis we have months, and in the y-axis we have length. Then the growth points we can see. So how many visits the child has? 5 visits. So the growth pattern is observed. Okay. So it is along the median, or above the median, or below the median. Along the median. So child is healthy, yes. So this is how we have to interpret it. We can do it practically in the afternoon session, okay?
How many years of work practice?
It is still it's normal. Yes. Concern pattern. Sharp incline, sharp decline, and flat growth. What is sharp incline? That is the child is growing at a faster rate than expected. This is also a concern, no? Then sharp decline. The child may not gain adequate weight, maybe due to illness or nutritional deficiency. So it is also concerning. We have to rule out the other risk factors also. And then flat growth, there is no change. It's static. So it is a flat growth. Next is concerns with growth, with the length and height, with the weight and with height. So first is length and height. In length and height, you see the stunting. A deficiency in height is called as stunting. Yes, we can rule out from the WHO growth chart. We can find out no. Stunting is defined as length or height for age Z-score below -2. It is a result of undernutrition due to feeding difficulties or poor diet for infants with cleft palate. Next, concerns with weight. First one is waist. Weight is it is acute malnutrition is defined as weight for length or height Z-score below -2. Underweight is defined as weight for age Z-score below -2. That is for length and this is for age. Underweight is for the age and wasting is for the height or length. Then concerns with the head circumference, microcephaly and macrocephaly. So microcephaly is the head circumference for age Z-score below -2 again. Then it may be the reason may be chronic malnutrition or certain disabilities like cerebral palsy. And then macrocephaly, it is head circumference for age Z-score above +2. It may be caused by extra fluid surrounding the head, hydrocephalus, any other genetic conditions. Fine. Let's clear the WHO growth chart. Any queries?
like information we have WHO and the software is there. So if you read the interpretation, what you are getting the measurement, you will give the result. Whether the baby is in the minus X score or below the minus X score or above the median line will give the result. So that track sheet will be if the smile train drawing some of the hospital they are maintaining. Still, we don't have exclusive nutritionist project, we are not maintaining that. But so many hospitals are maintaining the nutrition tracking, right? And also, both tracking app is there. You can download the thing and you can see the measurement what you are getting from your child, and then you can get the result, right? So whether baby is in a median line or below that's below -2 or above this thing median line 0. Can easily interpret. Any doubts you have? No? Then you want any break or shall you want to one translation is we finish and you have this, right?
Since the take home message, if all of this come together with the children, we can say it in all. So we can keep this in mind. Many queries also you can ask. Thank you for your time. Hope you all understand.
All the primary textbooks and state government and ANMs and ANMs are maintaining, but in Jitma pediatrician only maintaining that side only, no, pediatrician only maintaining, but it's very important you to know and how to interpret the growth curve when the baby comes to you, right? For that only education has been done.
Thank you, Mr. Lakshmi ma'am. Now I call upon Mrs. Rafi George, nursing officer, to deliver the speech about post-surgery care and nursing care.
My presentation, myself, Rafi George, nursing officer, 145 hours. So as you can see on the screen, today my topic is post-surgery diet and nursing care following cleft lip and palate surgery. So in the previous sessions, our speakers have already explored several topics under cleft lip and palate surgery. Sorry, cleft lip and palate. So to recap, cleft lip and palate, it means it's a congenital birth defect which involves an abnormal separation in the lips and roof of the mouth. So babies who are born with these types of defects, they will be facing feeding difficulties and speaking difficulties. In case of feeding difficulties, what will happen to the baby means they won't be able to form a proper seal around the nasal and create the suction. Thereby, it will be leading to nasal regurgitation, increase the swallowing of air, and also there will be insufficient milk intake and poor weight gain. So, in order to improve a child's ability to eat and speak, we are repairing these types of clefts. Usually, the cleft lip is done between 3 to 6 months, and cleft palate usually between 9 to 12 months. So, moving on to my topic, today my topic is post-surgery diet and nursing care following cleft lip and palate surgery. First one, as a caregiver, do you think that a special diet is necessary after cleft lip and palate surgery? Yes or no? Yes. So we can see one by one why a special diet is necessary after cleft lip and palate surgery. First one is to protect the surgical site. That means after cleft lip and palate surgery, what will happen means the area around the repaired cleft will be very delicate and vulnerable. So in that case, if we are introducing hard foods means it will irritate the baby and there will be delayed in wound healing and also it will cause infection. Second one is preventing damage. Preventing damage means if instead of the recommended post-surgery diet, if we are introducing hard, crunchy and sticky foods, these types of foods will irritate the suture site. This will also lead to improper healing and delayed, it will also promote infection. Third one is ensuring adequate nutrition. Ensuring adequate nutrition means we should provide after, before surgery also baby needs a well balanced diet, and after surgery also baby need a well balanced diet to recover and regain the strength. The last one is comfort and ease of feeding. Comfort and ease of feeding means if we are allowing the baby to eat easily digestible and soft, non-irritating food, the baby will be eating comfortably, and also we can reduce stress and pressure on the suture side. So, moving on to the points, first one, protecting the surgical side, preventing damage, ensuring adequate nutrition, and the fourth one is comfort and ease of feeding. Clear for you? Okay, we can move on to the next slide. What are the goals as a caregiver after the post-surgery diet? We should be aware that the goals are mainly divided into primary goals and secondary goals. So primary goal means we should ensure a soft, non-irritating diet to the child. That means it should not irritate the child's mouth, and also we should minimize the trauma. And we have to ensure hydration. That means the baby should have adequate fluid intake. Next is we are facilitating safe and effective feeding. That means with proper guidance, we are giving preoperatively, we are giving guidance to the parents about the different feeding techniques. Then only we can achieve our goal after the surgery. Then ensure proper healing. Ensure proper healing means that we are not at all irritating the suture site and damaging the suture site and causing any infection or bleeding. So the primary goals. The secondary goals is first we are introducing a non-irritating soft diet. So secondary, after the suture is healed, we are introducing normal diet. That is, we are helping the child to have normal diet by the fourth week of the post-surgery through introducing a variety of foods as the child is tolerating. And also secondary goals, the supporting our good healing, and we have to prevent the complications. So the goals are mainly divided into primary and secondary. Is it clear? Next is recommended diet following cleft lip and palate surgery. So immediate post of what all things we will do? Plastic surgery, I think things are here, no? Please explain. Because only away we will leave the child empty. Then in 48 hours, what we will do? Yeah, we will be introducing clear liquids. Clear liquids like the plain water or either coated water. Then in ICU, anything you will 25% dextrose to increase the energy of the baby. That baby should not go down into hypoglycemia. So that's why we are giving 25% dextrose in plastic surgery. So after 48 hours to 2 weeks, what will be introduced? Coming to plastic surgery ward, we are receiving the basics of plastic surgery ward. What things? Yeah, we will be introducing juices and milk that are double fits. Why we are double filtering the juices and milk? Yeah. We are preventing the from being lost, right? Thereby preventing the infection and irritating the suture site. And in case of cleft palate surgery, we are recommending clear non-acidic juices like apple juice and white grape juice. But in our plastic surgery ward, what we are doing? We are giving sathupudi. What happens to sathupudi? Sathupudi will be irritating the mouth after surgery because it's very sensitive after the surgery. We should avoid citrus juices like orange juices, grape juices after surgery. Is it clear? So on the picture we can see clear apple juice, milk, and it should be double filtered, not orange juices like sathupudi. We have to give apple juice and white grape juice, and also like white grapes. Next is recommended diet following. Sorry, next is after. So we must see 2 weeks a liquid diet we are giving like juices and milk double filter. Next is after 2 weeks we are introducing mashed foods like what our sisters said. First we have to introduce cereals, then slowly we have to introduce pulses, then fruits and vegetables like in mashed crop. Then after COVID, we are helping the child to return to the normal diet by introducing a wide variety of foods as the baby is tolerating. So these are the recommended diet following cleft lip and palate surgery. So immediate post op will be keeping the child NPO in 48 hours. There will be clear fluids like water, not water like 25 weeks. 48 hours to 2 weeks, we will be giving juices, milk. And after 2 weeks, mashed foods. And after 4 weeks, normal diet. Next, we will move on to the items, that is food items we should avoid for the first 2 weeks after surgery. So one by one, can you tell what are the food items we should avoid for the first week? Hard foods, then solid foods. Okay, then carbohydrate drinks. Carbohydrate drinks. Okay, one by one. As already we have discussed that lymphatic surgery you should not recommend citrus juices. That is grape juices, orange juices, and packed juices. Packed juices is also acidic in nature and it will contain so many pulps and seeds and shards will be there. So it will get lodged into the stomach size. And also hot drinks. Why hot drinks means after surgery? There will be anesthesia effect around the suture site. So baby will be having numbness around the suture site. So they won't be able to identify. Child won't be able to identify whether it is hot or cold. So there is a chance of burns. So we should avoid hot drink. That's fine. As you said, the hot foods, crunchy foods and sticky foods like lollipops, then cookies, brownies. Then foods that contain junk spices, things like nuts, grains, everything we should avoid for the first 2 weeks of post surgery. And also we have to avoid finger foods like finger chips and breastfeeding. Why breastfeeding should be avoided for the first 2 weeks? Yeah, the gate negative fraction will put more strain on the suture side. So it will create more tension and can lead to wound resistance. So it will again baby will go into again we have to do surgery. So we have to avoid breastfeeding or left hip and left palate. Left hip for 2 weeks and left palate 1.5 months we have to avoid it. So next is when going first we have seen the foods we have to avoid for the first 2 weeks of surgery. Next we can go to the items which are we should avoid for the first 2 weeks of post surgery. Okay, can you tell what are the items we have to avoid? Yeah, one by one. Diksha. What? Yeah, bottle plate. Then Manju sister. 1 point can you tell? Items to be avoided. That's awesome. Okay, anything from the group? Suggestions? Yeah, balls and all. So you can see one by one. As teacher said, that bottle feeding you should avoid because bottle feeding it can create irritate the suture site and it can lead to infection. Straws means again we are creating more pressure to the mouth after surgery. So it will also create more tension to the suture site. And then finger, avoid the infants putting the fingers into the mouth after the cleft lip surgery and cleft palate surgery. And also don't give pacifiers to the children for sucking. It will also enable next sucking procedure like creating again suction and it will create more tension of the suture site. And as Sudarshan said, we have to avoid hard play items like the rattles. Not be given to the babies. They are playing with rattles means it will cause trauma to the suture side that will lead to bleeding. And also the child is cleft palate surgery child means we should not avoid toothbrushing. We should not brush the teeth. Instead of that, we should clean the teeth and gums with a cotton pad only. We should not use toothbrushes for after the post surgery. So bottle feeding, straws, toothbrushes, then finger sucking, pacifiers, and the crackles. And one more thing. Can anyone click on this? It's not in the picture. One more thing is there. Brushing. Brushing always also serves. One thing is missing in this picture. Baby dress. How to be dressed? Yeah, exactly right. Front open dresses we should provide to the babies. Why? Why front open dresses? Yeah, if we are removing the dresses, it can cause friction towards the suture side. So we should provide front open, soft, fabricated cotton clothes for the babies. Next is, what are the items used? And as I said in the white, the surgery diet is simply that we are giving comfort and ease of feeding. We are introducing different feeding techniques. So, for these types of feeding techniques, we have to use several items. So the items we are used to feed the after post surgery mainly soft foods like a silicone spoons we can use. Then paladine feeding. That is, we are avoiding breastfeeding for the surgery. So instead of that, we are using paladine. Then for a cleft palate child, we are using open cup for taking the juices and milk. So in case of we are avoiding the breastfeeding, what we will do, what the mothers will do. Yeah, the mothers will be expressing the milk and store their milk. So their expression and storage of milk we will be discussing in the afternoon session. So is that clear for you till now? So to summarize, we have covered why the diet is important, our goals, then what are the diet we are recommended, then what are the foods we have to avoid, what are the items we should avoid, then what are the things we are missing for feeding our child after birth. Next, we are moving on to the assessment. What all things we will assess after cleft lip and palate surgery? Contributor points, bleeding. Tell me.
Bleeding from surgical site.
Bleeding?
From surgical site.
Yeah. Next. Yeah. Good. Next. More points from this side. Parvati. Point. Okay. Thank you. Okay, nursing care assessment. First, we can see we have to assess the surgical side. Why we should assess the surgical side? We have to see if there is any redness, any edema, and any pus or drainage coming from the surgical side. Next, we have to monitor the infant's feeding tolerance of new feeding techniques. That is, pre-operatively, baby will be in a breastfeed or a bottle feed. Now, post-operatively, we are changing the feeding technique. So, we have to observe whether the baby is adapting to the new feeding techniques. How we will observe the baby's adaptance? How we will assess? We should assess the behavior of the baby. Whether baby is comfort or what? We have to assess and we have to assess whether the baby taking adequate volume of feeds and whether the baby is getting tired after each feed. These are things we have to assess. Then we have to assess the infant's hydration status. As we have already discussed that we have to check the diaper. Then monitor infant's weight gain. If the baby we are doing surgery at a weight of 6 kg means post-op goal should be what? The baby should maintain the weight or not? Yes, the baby should maintain that weight after the surgery also. And overall well-being like Parvati said, vital signs, physical appearance, behavior, family support, access for potential complications. So moving on to the nursing diagnosis, what will be the nursing diagnosis? After surgery, common medicine diagnosis. Yeah. Right. Okay, we can see one by one. Risk for infection, impaired tissue integrity, ineffective infant feeding pattern, and leads to imbalanced nutrition. Risk for bleeding and risk for injury. Yes, what happened? Okay, moving on to the nursing care following cleft lip and palate surgery. So we can see one by one in detail. First one is protecting the suture side. So what as a caregiver, what all we do to protect the surgical side? Plastic surgery, what thing? What? Everything we will do. What? And ICU. Yes, very good, very good.
Nothing should be all over the.
Very good, very good.
After each meal, we have been right clear water.
Yeah, very good, very good. Next.
We have been already for pain management.
Main thing is we have to avoid the touching the surgical site. Is it necessary that we should not touch the surgical site? If touching the site means we are irritating and trauma to the surgical site. For that, what we will use? Elbow restraint. It is usually used in outside India only. Here we are not using. Here what we will use? Yeah, touch. We will be using mid and only to prevent the baby from touching the surgical site. Or also there we can use restraint. Here you can see the restraint. Here we are not using, but then I am showing. Next is incision care. As the sister told us, we should keep the incision clean and dry. And in what we are saying that we are applying the steric. Steric means the steric. The adhesive tape. We are attaching the cleft lip repair. After the cleft lip repair, we are attaching the steric. Why we are attaching it? We are helping to support the surgical tissue and reduce the tension on the repaired area. So we have to avoid touching using immobilizers. Then we have to take care of the incision and we have to apply steric strips. Then coming to the feeding and nutrition. Feeding and nutrition, what we will do? Yeah. But we have to avoid sucking. That means already I told now, we have to avoid pacifiers, finger sucking, everything we have to avoid. We have to switch from breastfeed to palatine feeding. In an easy and comfort way for the baby or spoon or a cupper. For introducing this palatine feeding, preoperatively we have to educate the mother how to. Some mothers may not be knowing how to use it and how to feed the baby. So we have to preoperatively or we have to educate the mother. Then how to hold the baby while feeding? For cleft lip and palate surgery. Yeah. The baby should be in an upright semi-seated position while to prevent the backlog through the nose. So we have to hold the baby in an upright semi-seated position. And also while feeding we have to protect the surgical site as Avia has said that should not cause any trauma to the surgical site. And also after the cleft palate surgery, child should not be allowed to feed by themselves. We should supervise while giving each feed. They should not be allowed to self-feed for 1 or 2 days because we have to protect the suture site. Then make sure our food is not hot because we should avoid burns in that area. Next is feeding progress. Feeding progress means we have to monitor the infant's feeding duration. Whether the baby is taking each feeder within 30 minutes. That is the maximum duration we can tell. More than that, if the baby is taking means get easily tired. Then amount of the pallida, how much amount of, how many pallida the baby has taken, we have to ask the mother. Then only we can assess the baby is getting enough nutrients after the surgery. And also we have to monitor the weight gain. That means preoperatively if the baby is, should not go to 3 kilo. That should be our nursing care intervention should be allocated to regain the weight of the baby. Then ensure the baby is having enough fluids after each diet. Then we have to avoid straws and the toothbrushes. That will it will cause more pressure. Then after each feeding, burping is essential. In an upright position because there will be swallowing of air, so we have to frequently burp the baby. Next is mouth care. Mouth care, I already told that we should not brush the teeth. Instead of that, we have to clean the palate. That means we have to rinse the mouth. After each meal, we have to take a drink of water to clear the teeth. Then we should not use toothbrush. Then we have to clean the only teeth and gum. That is not the toothbrush, it's the gauze pad. Basically plain water, the mouth care. Next, coming to the infection prevention. Infection prevention mainly what will be the main highlights? Hand hygiene. That is before feeding the baby and after feeding the baby, we should maintain hand hygiene. Not only the hand hygiene, what are the things we are using for preparing the food. That also we should emphasize. We should preoperatively educate the mother. What are the importance of food safety and hygiene? As already Jayalakshmi explained, the sister has already told me the importance of hand hygiene, food safety. We have to, as a caregiver, we have to follow all the 7 steps. It's palm to back, back of hands, finger interlace, finger interlock, base of thumb, fingernails and the wrist. Next, we have to monitor for signs of infection. That is like fever, redness, swelling on us at the surgical site. Mainly, we will be monitoring vital signs, temperature, for high fever, checking for any tachycardia, then increased respiratory rate, then oxygen saturation by there can be a risk of aspiration. So it's all important to check the respiration, oxygen saturation, and for temperature, pulse rate, we have to check for signs of infection, and also the site also should be checked. Next, we have, is it important that we should check the signs of dehydration? How will you check the signs of dehydration? Intake and output, then output, yeah, fill and tangle. Then that diapers, how many diapers injured? Then whether intake and output, observing the number of wet diapers that if the child is drinking adequately using specialized feeding techniques. That is whether the child is accepting the adequate amount of feed. Then what the signs of dehydration, we all know that if there is any fewer wet diapers, it is a signs of dehydration. Then sunken eyes, dry mouth, then there is no urine output for 6 hours. These are the signs of dehydration we have to check. Next is we have to monitor for complications. What will be the complications following surgery? Breathing, infection, airway obstruction, breathing difficulty, palatal fistula, scarring, and bone development. These are will be the main complications following the surgery. Next is pain management. Pain management, they will be prescribing paracetamol for the baby 3 times a day. So we have to administer the pain medication, especially during the feeding, and we have to encourage fluid. Then about the activity and play, how we should provide activity and play as the caregiver. What all things we have to teach parents. You have to allow the child to play quietly and calmly. You should not allow rough play or contact sports. That means you should not allow the child to put any objects in the mouth, and do not let other children also to give these children any hard objects. And also if the baby wants to play now, we can use all toys for the music. For the activity as a class. Next is follow up and appointments. Follow up and appointment means we have to schedule a regular follow up after cleft lip and palate surgery. The cleft lip, in cleft case of cleft lip, the stitches we will remove after 5 days, and in cleft palate, the stitches are already absorbed. So the next visit after cleft lip and palate surgery is after 2 weeks. Then the speech therapy they have to follow. And the plan for once the cleft lip is done, next cleft palate repair plan will be after 6 months. And also in discharge advice, we have to mention prevent the child from putting the finger in the mouth and to promote interactive learning. The baby should be afforded activities and mobiles. They should promote interactive learning. Then we have to ensure the parents understand the need for follow-up appointments with the surgeon and other specialists. So these are the follow-up appointments following cleft lip and palate surgery. Thank you. After post sharp 2 p.m. session will start. Thank you.
Hola. You also take it?
I'll take it.
Yes.
Hello.
Call me.
എല്ലാരും ഉണ്ട്.
எல்லாருமே ஆஃப்டர்நூன் சைக்கிள் சைன் பண்ணிடுங்கப்பா.
பிளாஸ்டிக் சார் ஐசியூல இருந்து எல்லாரும் இருக்கீங்களா? பீடியாட்ரிக் சர்ஜரி வார்டு சாரி பீடியாட்ரிக் சர்ஜரி வார்டு பீடியாட்ரிக் சர்ஜரி ஐசியூ அண்ட் தென் WCH ல இருந்து 10 பேர் வந்தீங்க. 1 2 3 4 5 மீதி பேரு பீடியாட்ரிக் கேஷுவாலிட்டி பிக்கு நிக்கு அதுக்கப்புறம் என்ன வார்டு பீடியாட்ரிக் வார்டு கேஷுவாலிட்டி சாப்பாடு இங்க தானே கொடுத்தேன், எங்க வெளியில போனாங்க? சரி போன் பண்ணி உங்க போன் நம்பர் இருக்குல்ல, அவங்களோட கான்டாக்ட் நம்பர் இருக்குல்ல, கொஞ்சம் போன் பண்ணி கேளுங்க. அப்படி இல்லைன்னா ரெஜிஸ்ட்ரியில இருக்கு, போன் பண்ணி வர சொல்லுங்க.
ஐயோ
இருக்காங்க 8 members has to come.
வந்துருவான்டா. டேய் தம்பி வந்துருவான்ல. வச்சுட்டு போயிருக்காங்க. வந்துருவான். மஞ்சு ஏதோ சாப்பாடு கொடுக்க போயிருக்கான்றாங்க. வந்துருவான்ல. வந்துருவாங்க.
நம்ம இப்ப இருக்கிறவங்கள 3 செக்ஷனா பிரிச்சுட்டு வர்றவங்க 7 பேர்
இதுல எடுத்துட்டீங்கன்னா எப்படி வாங்குவாங்க? அவர்கிட்ட எடுத்துட்டாங்க அந்த போட்டோ
அவங்க வாங்குவாங்க. வெயிட் பண்ணலாம், 10 நிமிஷம் வெயிட் பண்ண 2 மணிக்கு
That's all. So, இப்போ 21 members இருக்கீங்க. Audible இருக்கா? Yes. So, 21 members இருக்கீங்க. So, which means வந்து 7 numbers are room number 1 ல then concerning keep the room demonstration.
இருபத்தோரு பேர் தான் இருக்கிறோம்.
யாருக்கு 700 நினைக்கிறா
Orthodontics है सारे मलयाली కొంచెం
இங்க வச்சு ஆஃப் பண்ணாங்க தெரியல. எஸ், ஆஃப் பண்ணிடுங்க.
setting அப்படியே இருக்குமா அப்படியே இருக்குமா
ஆமா அந்த தப்பு